Good morning. I think we may as well get started, and it does really give me great pleasure to welcome you all to Melbourne and to this wonderful day, the Impact International Workshop 2024. There's a couple of things I've just got to run through before we get into the proceedings, if that's okay. And firstly, I've got to show you this. Okay, so we don't anticipate any emergencies, but just in case, if there are any emergencies, you simply go out this door here, you go across the road, and you muster in the car park. Okay, if you want to be adventurous, there are some basketball courts you can muster in as well, but we'll kick off with the car park. So that's just literally, if you can imagine, I can't. You're about here, you're going to go out this door and you're going to just go across that road and muster there. Okay. The next thing I should do is an acknowledgement of country, and all of the Australian synchrotron recognize the first people of this nation and their ongoing connection to culture and country. We acknowledge the First Nations peoples as the traditional owners, custodians, and lawkeepers of the world's oldest living culture, and pay respects to all Aboriginal and Torres Strait Islander people, past, present, and emerging. So it is, I want to thank you for being here. I know it's always, thank you. It's always a large effort having to travel significant miles, and certainly we're very grateful for our Italian colleagues for being here. It is about 10 years ago since I was introduced to this very clever man over here, Professor Tim Guriev, who came into my office in Sydney, and I remember the feeling of excitement and privilege that in some way I could be part of this very interesting and extraordinarily interesting work. I still feel somewhat of a fraud being surrounded by these brilliant physicists, radiologists, surgeons, radiographers, engineers, health informaticians, project managers, etc., etc. But certainly what you can see there is the multidisciplinarity of what we do. And I have, for over 3 decades, heard about the importance of multidisciplinarity in universities, and I really cannot think of a more comprehensive display of multidisciplinarity, and as we see in this project, that encompasses such a range of skills from a range of people, so incredibly easy to work with. And it is incredibly reassuring that I can see the next stream of the team coming along. I can see these young academics arriving, the new postdocs, the PhD students, even the honors students, sort of entering this project with enthusiasm and lots of activity, and we're indeed very, very grateful for that. Ancora una volta è per me un grande piacere accogliere i nostri amici in visita dall'Italia, in particolare dal Trieste. Ho tanto bei ricordi dei miei viaggi per incontrare Maria, Renata, Giuliana e Maria. L'unica tristezza è che Maria non è qui con noi. So after 10 years of this work, I think we're really now at a critical point. We're literally months away from what will be the world first clinical trial around phase contrast and CT. I have no doubt there will be major issues and major hurdles, whether it's jitter, flat fields, patient recruitment, legalities, permissions, whatever. I'm also absolutely, I have no doubt that this team will get across those hurdles. And finally, to today's workshop, and thank you, Magdalene, and Daniel, and Amir, and Tim for driving this forward. but it gives us a great opportunity to hear from all our clinicians and scientists from Italy, from CSIRO, and all the director leads for projects 1 to 4. I certainly look forward to these updates and discussions so that we can move to the next 10 years and the clinical realization of phase contrast CT. So with no further ado, I'm going to welcome our first speaker. Yeah, thank you. And our first speaker is Professor Renata Longo. She's a full professor of applied physics at the Department of Physics at the University of Trieste, Italy, and research associate at the Italian Institute for Nuclear Physics. She is director of the Master of Advanced Studies in Medical Physics, jointly run by the International Center for Theoretical Physics and the University of Trieste, and her scientific research focuses on medical imaging, and particularly development of single photon counting spectral detectors and X-ray phase contrast techniques. She has carried out research in both clinical applications and preclinical studies at the synchrotron radiation facilities, and is the author of more than 200 publications, papers, and we really welcome Professor Longo to give this initial talk. Yeah, thank you. Yeah.
Can you hear me? Yeah, thank you. Good morning, everybody. It's a pleasure to be here. It's an honor to have the first talk of this workshop. And okay, as a member of the advisory committee, I've chosen the topic of my talk with the hope of being of help for the program. So I'm going to discuss with you the new breast dosimetry model. It is the result of a joint activity of the American Association of Physicists in Medicine, of the European Federation of Medical Physics. And then I'm going to discuss with you what happened beyond the cone beam breast CT. Then we move towards the photon counting CT and the associated technique like material decomposition. We are going to find some surprises and some promises. And then we go to the research in breast CT, like grating interferometry and something like this. So, new breast dosimetry model. The traditional model for breast dosimetry is the homogeneous breast with homogeneous distribution of water and fat. However, obviously it is not the best model according to our knowledge of the breast anatomy. So now we have new breast model representative of the current understanding of breast anatomy, including different breast size for different compressed breast thickness, because this is a model for mammography and if it is not mammography, it is tomosynthesis, I'm sorry. And then we have an appropriate breast skin definition, because you know that up to now we have a European and USA model with different skin definition and with different effect on the dose calculation. And moreover, we have a new reprograndular tissue amount and distribution reflecting what we have found in the population. So moreover, the new methodology of a realistic field X-ray field, including the Hill effect and so on. And in order to go up to the end of this project, we have performed the computation of monoenergetic conversion factor, allowing us for computing the spectral conversion for a different X-ray spectrum without the need of upgrade with a new version of the model or the technique. We have defined a single new reference incident pair KERM, and now the software is available for free in order to use this model. But what is new? The new is that nowadays we have the volumetric breast density that is calculated thickness by thickness, and it is calculated in terms of percentiles. So the standard breast is what is represented by the median percentiles, and so you have that we move from different volumetric breast density, obviously from the thinner to the thicker breast, and so you see this is what happened. So this is about the volumetric breast density, and then we have calculated a 3D breast model. So the shape of the breast obviously is different if the breast is thin or if the breast is thick. So we have the shape, we have the profile of the breast, and then we have a new model about the distribution of the fibrograndular tissue into the breast. This is obtained from 88 dedicated breast CT images. And so you see that we have a different distribution with the glandular fraction of 20% up to the glandular fraction of 50%. Because the glandular fraction is never higher than, in terms of volumetric breast density, is small than 30%. This is what we observe. Okay, now the software is available for, and with the software, what happened? It happened that we have to define select the breast mode. Oh, sorry, let me choose that. Okay, so we have to define select the breast model, the acquisition, the modality, digital mammography, digital breast tomosynthesis, contrast enhanced mammography, and contrast enhanced breast tomosynthesis, the geometry of the scanner, we have to define the spectrum, and the results is that we have a different average glandular dose according to the different possible thickness. And when we move from one thickness to another thickness, we have different volume density, and the 5 number, because we calculate the dose, the average glandular dose, 5, 25, 50, 75, and 95% of percentile, not granularity, but percentile. So this is what is going on nowadays, and even the manufacturer of mammography are going to implement this new model. The result of this model is that the average glandular dose is reduced, the reduction is about 30% in average compared to the old model, because in this model we have the glandular tissue is in the center, and so we have a lot of energy that are delivered to the fat that is in the external part of the breast, but the energy delivered to the breast, to the fat, is not contributing to the average glandular dose. Well, is this model universal? Well, we think yes, because this model has been calculated in more than 4 million images, and the sample have been obtained from a lot of images from a lot of countries. Now we have you see the median percentile according to different countries. So what is next? Okay, this is the publication. What is that? Now there is a working group of the American Association of Physicists in Medicine that is working in order to implement this model for breast CT. We are running now the Monte Carlo calculation, and okay, we think that the largest part of the work has been done in the previous working groups, so we hope to be ready in maybe 1 year. The problem of the breast dosimetry in breast CT is not a new one, because even in 2022, the team that is working in Zurich, that is working with the photon counting spiral breast CT tomography, they perform a study about the dose delivery in breast CT with again with their data set, with the segmentation, Monte Carlo study, and so on. So this is one point of attention, in my opinion, to be aware of what is going on in breast dosimetry in order to be able to share the information that between the data that we are going to acquire in this synchrotron with the data that are calculated from the other people working in mammography and working in breast CT. Well, breast CT, all of us knows very well that cone beam breast CT suffer from low spatial resolution and low contrast to noise ratio. We published this paper, but Christian, Juliana, and team published another similar paper with the tissue sample. This is a phantom study. So even if the quality of the image is not so amazing, our colleagues are still working in cone beam CT in order to optimize the protocol for contrast enhanced imaging. So contrast enhanced imaging in breast CT is an important technique that is increasing the fraction of mammography is contrast enhanced. Maura is going to tell us something about this. And so cone beam CT maybe still have a role in breast imaging. Contrast enhanced screening for patient risk maybe for sure for the artificial intelligence based post-processing. So this is about now let me move towards photon counting CT. Photon counting CT, not breast CT dedicated, but photon counting CT. Photon counting CT is a long journey. I mean, but nowadays there is one manufacturer that is on the market, and the user of this photon counting CT says that they are very happy in terms of low noise, high efficiency of and low dose, and high spatial resolution. This is an example. In order to let we even I would like that we pay attention to these 155 in-plane micron in-plane spatial resolution is a very good spatial resolution, and moreover it is possible to perform noise reduction or dose reduction. Is the usual compromise that the user have to decide, and moreover the spatial resolution has been reported as a very good as an example in this application. And this is a small surprise. This is a paper that was published by the team working in Netherlands. This was online in May 2024. This is what we call opportunistic imaging. I mean that they evaluated the image quality of breast examination in photon counting computed tomography. It's a phantom study, obviously. So this is not a scanner devoted to breast, but the question is, what is the quality of the breast images in this opportunistic examination? Well, this team works a lot with cone beam CT, and according to their experience, the clinical photon counting CT provide an image quality superior to that obtained with the cone beam breast CT in terms of normalized contrast to noise ratio, and allows the identification of calcification of fiber. And so for me, it was a surprise. Pay attention that this is going on. Moreover, if we have a photon counting detector, we can play with multiple thresholds, which means that it is the spectral imaging is what we expect to be done with photon counting, which means that it is possible to perform contrast and static sum with one single shot, and then perform the post-processing and perform material decomposition. You remember the material decomposition idea? The idea is that every voxel in the image can be described as a linear combination of two basis material, and these two basis material that must be computed at different energy. And in such a way, we can calculate the weight x1 and x2 that describe this material decomposition. Well, this approach is the cornerstone of clinical tasks such as iodine quantification, virtual monochromatic imaging, and the evaluation of the density and the atomic, I think it's not mine, and the atomic number. So these three tasks are very interesting for a clinical application. However, when we perform photon counting imaging with multiple threshold with the conventional X-ray tube, we have to be careful, because ideally, if we apply a threshold at 60 keV, as in this example, the first channel will collect all the photons below 60, and the second channel all the photons after, higher than 60. But this is not true, obviously, because we have charge sharing, fluorescence escaping, so we have a lot of, due to the physics of the interaction of the photons with the semiconductor sensor. And so what happened, it happened that in the first channel, we collect information not only about the photons at energy lower than 60 keV, but even we collect information of photons with energy higher than 60 keV. This means that, and this is true even if we apply more than one threshold, 2 threshold, 3 threshold. You see that if we apply 3 threshold, we should be able to acquire 1, 2, 3, 4 energy channel, but in the realistic detector response, we have much more complicated response. So this is in order to say that it is not trivial to perform material decomposition when we in clinics and when we work with a continuous X-ray spectrum, even if we have a state-of-art photon counting detector. There are photon counting detectors that are able to perform some compensation for the charge sharing, but they are not applied now in clinical application. The clinical application scanner nowadays, the clinical scanner nowadays does not compensate anything of this, and so they are working exactly in this condition, and so the software for the material decomposition have to be optimized in order to do the best. However, our radiologists are familiar with iodine quantification, with virtual monochromatic images, and even with the map of density and effective atomic number. In order to do this, we perform the material decomposition using PMMA and aluminum. Well, but this is with the scanner, that for the whole body scanner. What is going on with the breast CT? Well, there is one manufacturer that developed a photon counting breast CT. It is slowly coming in clinics. It is a spiral CT. We can say that it is 1.5 dimension detector, because the detector is a few centimeter height, but it is necessary to perform the spiral acquisition. In such a way, there is a good scattering rejection, so the quality of these images are associated with high spatial resolution high efficiency, good spatial resolution, and good scattering rejection. Spectral imaging is not viable yet with this company. However, there is in my opinion, as a physicist, it's not my job to describe the quality in terms of diagnostic properties, but this is an interesting result. This result was published in 2024 by the team that works in Zurich, the same team that the same people that investigated the dosimetry breast model. Okay, they have a preliminary pioneering study with a limited number of patients, only 40 patients, but with paying attention to these 14 patients, they say that it is possible that in terms of Ansfield unit, it is possible to have a characterization of the malignant lesion and glandular tissue. They are different. So this is obviously they have the number are limited. It is necessary to go on with this kind of investigation. But if you have, but the message is that if you have a high quality image, so which means low noise, linear detector, and it may be possible to perform characterization of the lesion in terms of Ansfield unit. Well, if we want to investigate the characterization of the lesion, spectral imaging should be a tool. And so in order to, what we have done is a feasibility study using a photon counting detector, but using the synchrotron, in order to see what happens if we perform spectral imaging, spectral CT imaging of the breast. Obviously, when we work with synchro radiation, we have ideal monochromatic spectra, so we have not problem of the distorted spectral response, so we are a sort of gold standard. And we did this kind of study with a PhD student in Trieste. And what happened? It happened that we investigated, we performed material decomposition for a region in the fat, a granular tissue, and cancer area. So we performed the aluminum and the PMMA map, and then we calculated the weight of aluminum and PMA on the average value, as an average value for the selected cluster. And what happened? It happened that these are the samples that acquired in Elettra a few years ago. But I think that this is interesting. The results are interesting because you see that now we are able to show the data in the 2D plan. So the people in Zurich have only one quantity, the density, the Ansfield unit. Here we have density and effective atomic number. And what you see, it happened that, okay, the green point are the adipose tissue, it's not of interest. But the blue one is fibroglandular and the red one are tumors. And you see that if we are in the 2D space, we can separate the blue and the dot and the red dots. But if we perform the projection in density or in effective atomic number, the separation is not so heavy. So obviously this is a very limited amount of data, only 5 samples, but I think it's an interesting result that we can investigate because the cancer characterization is a sort of a holy grail of radiology. Well, and then let me share with you a few slides, just 2 slides about what is going on in terms of phase contrast breast CT, not at the synchrotron radiation facility. So this is a scientific reports paper of 2024, Munich, and because this is the inverse Compton source, and so the they say that they obtain very good results, very reasonable dose. Obviously, the inverse compound source, okay, it's a compact source, but it's quite similar to a synchrotron. However, I think that we have to pay attention because we know that the Munich team is carrying out a clinical activity in phase contrast lung imaging. So we know that they are able to interact with radiology very well. They are able to work with patients. So maybe they have all the knowledge in order to go on in this direction. And then there is another friend of us, is Marco Stampanoni, and he's working to develop mammography and breast CT with grating interferometry. Another paper of 2023. What is interesting in this paper, the interesting is that again we see Andreas Boss, that is the head of the radiology department in Zurich. So they are working. So these radiologists work with the photon counting breast CT unit. They are working with they are trying to understand if there are quantitative information that can be extracted, and they are also involved in this adventure. I suggest that we have to be aware of what is going there. So, in summary, what could be perspective in this field? Photon counting in clinics, we have to see what is going on. Maybe you remember that the photon counting CT scanner was developed at the beginning by Willy Callender, so it's a very important scientist in CT. Unfortunately, passed recently. And so photon counting in clinics is an interesting point. Phase-sensitive technique, propagation based in synchrotron. We are waiting for your patient. And grating or edge illumination with conventional sources. Clinical application, contrast enhanced screening for a selected patient, lesion characterization before biopsy maybe. And then an open point that I want to mention here is the breast motion and its compensation. That is an open point that as an advisory committee, I want to give to your attention. Thank you. Thank you so much.
Thank you very much, Renato, for that very stimulating first talk. Has anyone any questions for? Yeah. Thanks, Max.
Thanks for a wonderful presentation, Renato. Just you're talking about contrast enhanced. Are there specific contrast agents that people are using at all? Like, are they injecting contrast agents into the breast tissue at all?
Is an iodine contrast medium, and I suggest that we wait for the radiologist for this kind of discussion.
Okay. Wonderful, thank you.
Tim?
First of all, thank you for the great talk. It's so many interesting things which I wasn't aware of. So let's see. Thank you. So I say it again. Thanks a lot for the great talk and a lot of interesting new facts. I just wanted to ask your opinion about these efforts for achieving the phase contrast breast CT using gratings. So what do you think about the prospects of that?
I think that it's an hard task. So I think that it's not easy, because if they wanted to, in principle, all of these, okay, if you are with a compact source, you have to rotate the patient as usual. And as you know, and we know that it is not easy. And Marco Stampanoni says that he wants to create a rotating system. Now, I think that it's an hard job. I'm not. I think that they take a lot of years in order to be ready for patients. Absolutely.
I have to say that I thought that the data you showed on the spectral imaging was very, very interesting, and the effective atomic number and how you could differentiate between those different tissue types. Now, I know this is preliminary work, but do you want to make a comment on where that work might be going now?
I think that, okay, as a physicist, I'm very much fascinating because it's number, it's quantity that I can understand. And I was to be honest, I was happy to see this, the preliminary results of our colleagues in Zurich, because, okay, our study is only 4 patients. These are 40 patients, but if they are able to see something different, looking only at the Hounsfield unit, if we are able to collect 2 different independent quantity, we could be very much sensitive. The sensitivity could be, and specificity could be increased so much. It's a sort of challenge for you if you are able to to perform dual energy acquisition with the synchrotron, with using the higher harmonics, or I don't know. It's a challenge.
It certainly sounds very fascinating, and often one of the challenges here is that you see a big inter-observer variation, but I think in your work you actually showed that inter-observer variation was minimum.
Okay. For this study, they used 2 observers, and they declared that the variation between the 2 observers was very, very small. In our study, it was we have not evaluated this.
Any other questions? All right. Thank you very much. All right. Well, it gives me great pleasure to welcome Dr. Amir Taber, Professor Tim Guriev, and I don't think Darren is here today. No. Darren, for those who don't know, Darren is our breast radiologist based here in Victoria. So it's Amir and Tim, if you want to come up and okay. I should say most of you will know Professor Guriev. I remember his early papers in no less than Nature. He impressed me a lot when I met him a few years ago. And Dr. Taber is a PhD student of mine, postdoc of mine, and now is a senior lecturer at the University of Sydney.
Does it work, Jen? I should use a keyboard. Can use keyboard. Okay, that's fine. So good morning, everyone, and it's a pleasure to be here. So we are going with team talking about Project One in the impact. And for those who are not very familiar with the 4 projects in the impact, the Project One focuses on optimizing the imaging conditions in terms of software, hardware, and assessing image quality to guide the other projects. But the very first study that I'd like to report is, as many of you, there have been many studies looking at comparison of the image quality for PBCT, or as it's called, BCT, with our Australian colleagues, Australian synchrotron colleagues, with conventional CT or cone beam CT. But we have always had the desire to look at the diagnostic performance of the technique. So I think this is the first time that we are able to look at the diagnostic performance against digital mammography, which is the standard modality for breast screening. We measured sensitivity, which is the proportion of correct diagnosis on cancer cases, specificity, the proportion of correct classification on non-cancer cases, AUC, which combines sensitivity, specificity, and the confidence rating from the radiologists, and case-based accuracy, which is the proportion of radiologists correctly identified each case. And interestingly, all measures, all metrics were improved using PBCT against EM. We had 16 readers and 30 cases. Of course, the PBCT images were ex vivo mastectomy scans, and EM images or digital mammography images were in vivo screening images. So the first three metrics were not statistically significant due to low number of radiologists, but the case-based accuracy was significantly different. We also looked at the effect of radiologist experience, and for radiologists with less than 10 years of experience, we see a more prominent increase in sensitivity. For more experienced radiologists, we see a bigger jump in their performance in specificity, which is not very surprising. And that's very common with all new imaging modalities coming to clinics. Another study, there have been a few different studies, both in Australia and Italy, looking at the effect of image quality, effect of X-ray energy on image quality, but we were also interested to know the effect of breast density on that relationship, and if it changes that relationship. Jenna is looking at that as part of her PhD, and we found there is no really big difference. We are still, with both low density samples and high density samples, the SNR, signal to noise ratio, and signal to noise to resolution are increasing using higher X-ray energies. Visibility or contrast is decreasing using higher X-ray energies, and that somehow counterbalance SNR to res and contrast. When we look at the CNR to res, I think the overall message here is that 32 kV that we have been using mainly is still the most appropriate X-ray energy, but I should mention this is based on flat panel detectors. Using Eiger photon count detector, the result might be quite different. And also here, all samples were scanned using cylindrical containers, but in the clinic, we will hopefully use more cone beam. So again, cone shaped containers, so the effect would be a bit different as well. And there were some scans at the IMBL last year looking at the effects of energy threshold for the Eiger detector and the number of projections. And Thomas is now working on that. I think Chris has also looked at those scans before. So what we see here is mainly with reducing the X-ray energy threshold and also reducing the number of projections for CT imaging and CT reconstruction. We get lower or worse spatial resolution, but we get better signal to noise ratio. And this is the graphs for the number of projections. So if we consider the lowest X-ray energy threshold and the lowest number of projections as the optimal X-ray energy, optimal condition for the Eiger, Thomas also looked at that optimal condition with the scans of the same mastectomies and phantoms using the Xenius flat panel detector. So again, here we see that the Eiger has significantly better spatial resolution, but worse signal to noise ratio. But the overall performance in terms of signal to noise to resolution and CNR to res are in favor of the Eiger, which is very promising.
Good morning. Right, sorry, it's so little time, so many things to describe, so I'll have to be brief. But I'll start from the very recent results that were obtained by our new colleague, Dr. Ashkan Farzad, and a few other people. And those are results on AI-based denoising of our breast CT images collected at the synchrotron. So we happen to have 34 scans of different breast mastectomies collected both at a low dose, relatively low dose of 4 milligray, and a high dose of 24 milligray. So that was extremely useful for training an AI model using the high dose images as a gold standard. And Ashkan tried several different types of AI models in this context, but the best results so far have been obtained using UNet, which is a very popular approach. And here you can see one example of an improvement. Sorry, which button should I press? Sorry?
Someone.
Ah, it's not working. That's easy. Okay, can you see my pointer? No? So I don't know. Well, anyway, that's the central image I'm trying to describe. All right. Okay, excellent. Thank you so much. So, as I said, this is the part of a 4 milligray noisy image, and the part of approximately the same area of the 24 milligray scan of the same sample. And this is the image, denoised image, which was obtained from the noisy one. And as you can see, of course, it's quite clean, but the most important part that there is no perceptible or measurable loss of spatial resolution. So generally, we were able to demonstrate the improvement of the signal to noise by approximately a factor of 3.5 without the loss of contrast or resolution, which translates into approximately 12 times dose reduction, which is, of course, extremely promising. So we are now working on the first publication about these results. In conjunction with the Project 2, since the beginning of this program, the impact, we have collected 28 mastectomies using the EIGA detector. And since June this year, we collected 19 scans using EIGA in the, what we, I think, can now call the final patient configuration. And of course, there will be more details later in the reports from Project 2. So I won't go into the technical details, but you can see the general setup here. The mastectomies were placed in the breast holders and scanned with the patient bed, which was rotated by the robot. And since June this year, the EIGA detector was moved diagonally in the middle of the scan in order to cover the gaps in the detector. So, as I said, we now have 19 scans of this type collected at different energies, like 32, 35, 37 keV, mostly at 24 milligray dose with very large number of projections. So we will be able to subsample the projections to emulate lower doses, and it will be useful for AI training in the future, at least we envisage. Also, we scanned 10 phantoms that were 10 breast phantoms, which were created by Dr.-elect Engels for us using lard and egg white. And it turned out that these phantoms are extremely useful for as a test object. So we're going to use it as a reference data. We now collected scans using Xenius detector at different propagation distances. You can see those small holes, which is of course like air bubbles in the structure, which are extremely useful for estimating spatial resolution. It's interesting that the kind of nuisance artifacts in those phantoms turned out to be most useful features. So the other artifact was these poorly visible streaks, which are actually ice crystals in the egg white. And because they are low contrast features, they're also very useful for testing various reconstructing algorithms, denoising approaches, etc. So that's the reference data set which we are planning to release publicly, and hopefully other people can use it for testing their approaches. And my final slide is this one, where we compare three different phase contrast CT reconstruction algorithms: the conventional filtered back projection, the unified tomographic reconstruction algorithm, which we developed here in-house, and the customized simultaneous algebraic reconstruction technique, which was developed by our Italian colleagues, some of whom are here in the audience. And the results of the, we applied this algorithm to scans of 10 different mastectomies. And the results were quite interesting in the sense that the objective image quality metrics, such as signal to noise, resolution, etc., they consistently favored the reconstructions by the CSART algorithm, with one exception, which I emphasized here. The contrast was somewhat higher in the filtered back projection reconstruction, but all the other characteristics, including our favorite intrinsic image quality characteristic, which is the ratio of signal to noise to resolution in the appropriate power, they all favored CSART, as you see, quite consistently. Nevertheless, when we had the evaluation of the same images by imaging specialists and radiologists, we got the exactly opposite results. So the imaging specialists consistently preferred the results from the filtered back projection reconstruction, and actually the CSART came last. And the only explanation we have for here is that it looks like the imaging specialists favor contrast very much, and they can easily and effectively tolerate noise. So they don't care much about noise in the images, but they are very careful about contrast. And that's the only thing which correlates with our objective measurements. So we are also, hopefully we'll submit this paper for publication. So that's it. Thanks very much.
Thank you, Amir and Tim. Any questions? Thank you. Sorry.
Thanks, Tim, for that interesting talk, and Amir. To your slides, Tim, the two questions. If you go back to your first slide about denoising, just curiosity, I look at for example, the two images on the right, the top one and the bottom one. They're clearly different images. Are they different slices? Because the details in them are different. Is that true?
Ashkan, can you comment that we couldn't?
Yes, they are different. The high dose and the low dose are quite separately. So denoising is on the low dose image levels are quite separate.
So the fact that if I look at some of the details, that's because there are slightly different slices. That's nothing to be concerned about there.
And it's different scans keys as well.
Yeah.
So they were collected sequentially, but as you know, the samples can sometimes dry or sag in
Yeah.
between the scans. So there are always some
Yeah.
subtle differences.
Yeah. Okay,
But
thank
as you can see, it doesn't stop the algorithm from working.
sure. The other one is you talk about an AI model. I think everybody that knows something about AI is terrified about the fact that they're just, was in terms of these large language models, just plagiarism by another name, where you're just taking previous information and regurgitating it. Is that going to be an issue here? Is there will be, if you start, so it determines what sort of AI model you're using, but is there a danger that the interpretation of the images will ultimately be biased by the sort of the AI approach? Yeah, it's a black box, right? And we know you hear all the stories in the media about fake legal cases that come out of these large language models. Is this fundamentally different, or is that a concern that you think
Thank you very much.
ultimately you want to worry about?
That's a super interesting question, which we haven't investigated completely. And we hope to have a systematic study with the help by radiologists, where they would in particular look for any features that our AI denoising may have introduced in the images. So far, one of the positive messages is that we have noticed any. Right? So, but the other thing is that we have the theory which tells us that it is generally impossible to increase the SNR without losing spatial resolution. Well, here we clearly have this effect. We are observing the improvement of the signal to noise, contrast to noise, and the resolution actually is tiny bit improved as well, which goes against that theory completely. And that's what I think a positive outcome of what you mentioned is that the thing is using a priori information internally. The question is just how well it uses it, right?
Yeah,
There are some legitimate uses of that information because breasts are breasts after all, right? They are not legs. So if it somehow manages to use that information, that indeed all the images are coming from the particular part of the human body, that's fine. But if it turns out, we haven't observed that so far, but if it turns out, as you said, that it reproduces features from the previous observation, whatever hallucinating cancers, that would be, of course, a total disaster. But so far, we haven't seen that.
But you could argue that the increase in resolution could be exactly that, right? Which is a spurious increase in resolution based on previous models. Because if you
Right.
resolution is resolution, and noise, there are some fundamental underpinning principles here that
Well,
you're not going to get around, but you might think you are if you introduce these kinds of artifacts.
Sorry, what was that?
If you're getting resolution that the system intrinsically might not be able to deliver, then maybe that is this kind of hallucination, if you like.
Yeah, but in terms of resolution, basically there's no change. And whatever improvement is absolutely tiny, right, Ashkan? So for us, the main outcome was that there was no loss of resolution, because that's what I personally was afraid most of all. That certainly it's very easy to increase SNR by just averaging over, right? But to increase the SNR without losing resolution is the holy grail, right? So that's absolutely a fantastic result. So I would say that there's virtually no change in resolution, and maybe a tiny bit of increase, which would be associated with that noise reduction. Because God knows what we measure really when we measure the spatial resolution. It's not completely black and white.
Just adding that, I think what you say about black box is somehow true, and we should establish a mechanism for long-term control of the images produced by this AI algorithm. So even if we verify and validate based on sets of image sets in long-term for clinical application, there should be a mechanism of checking these images to make sure that what's produced is not.
Yeah. Ultimately, it's probably impossible, because if we want to image a patient which wasn't imaged before, right? And it comes back with some sort of a cancer. We don't know if it's real or not, unless we.
But I mean, on certain populations and up to now, there should be established a way to make sure the images that radiologists receive are not contaminated or have added artifacts on them. So, yeah,
We'll try.
yeah.
And you said earlier that the best image quality was at 600 projections.
Yes, I think.
Anyway, heard me. Okay, you said Amir that the best quality of the images was at 600
Not in
projections.
terms of spatial resolution, but in terms of signal to noise ratio. And then when we look at the SNR to res, as you see here, it was still around 20% higher for 600 projections.
So what do you think of that?
In terms of CNR to res, as you see, there's no big difference. So even 2,400 have a bit of higher CNR to res than 600. But in terms of other metrics, yeah, they are in favor of 600.
Tim, what do you think of that?
According to me, it shouldn't happen. If everything works properly, that's exactly what I just was trying to say in my previous reply, that in principle, it's all should compensate. One thing should compensate each other. Obviously, with the same dose, the images from 600 projections are higher.
Okay, so that for us is quite frightening. 600 projections is 3 seconds collection. So we would have to rotate the patient at something like 180 degrees per second, which means that we probably wouldn't keep the patient on the bed for very long because they will just be ejected. So, yeah, okay.
I think we have to maybe check these results. Yeah.
Yeah, this is still a work in progress and the paper is drafting, so we will definitely check it. Yeah, Lucas.
Thank you very much for the presentation. And yeah, I've got another curiosity about the AI slide. I'm sorry to keep going on that. So the results look really amazing, and I completely see that there's a 3 or 4 times improvement in the signal to noise ratio. I was wondering, there one could claim that you can reduce the dose by a factor of 10 or whatever, but that would be true in a linear world, right? If you apply linear operator, I mean, that's the relationship between noise and dose. It's true if you apply linear filters, whereas AI is far from being linear. God knows what it is. So I was wondering if you try to go like for with 1 milligray image and see what happens with the AI, because I'm not sure you can really reduce the dose by a factor of 12, as if it was a linear operator. I don't know. I'm just wondering.
Ashkan may correct me if I'm wrong, but in fact, in some sense, we have already done almost that. We compared images collected at 4 milligray with images collected at 24 milligray. So that's the 6th time reduction, right? But just as of yesterday, Ashkan also applied the same model to images collected at 2 milligray. The results were quite good, but maybe not perfect. But we certainly have an explanation why they were still suboptimal, because we didn't train the system for the 2 milligray images. It was trained on 4 milligray images and then just applied to 2 milligray images, and the results were good, but maybe with still some room for improvement. So it's a real demonstration of that, if you like, dose reduction in this sense.
Okay, thanks.
Thanks for a great presentation there. So with the different comparisons of the reconstruction algorithms, you had FBP and SART, for example. you definitely showed a clear improvement in contrast for SART, for example, or FVP, sorry. Just wondering, is potentially some of the reason that the radiologists thought that FBP was better possibly due to their training? They're used to seeing FBP, therefore they like FBP and therefore they think it's better?
It could be a case, but I just make a correction that even the subjective assessment showed that CSAC is superior to other models in terms of noise, reduction in noise. Of course. But as Tim mentioned, it looks like the radiologists rate contrast very high, so they can tolerate noise, and that's something we have seen in many studies. So they have a better tolerance for noise rather than contrast. So it could be also the way that they have been trained. So,
but in fact, it's quite a deep question, because you can ask what sort of a contrast we're talking about. If the reconstruction was just numerically correct, then we always get the same beta values for the adipose tissue and the glandular tissue. So the contrast in principle should be the same. Should be no difference in contrast, right? So what is evaluated as a contrast here probably has something to do with the sharpness of the boundary, right? So again, like in your recent work about resolution, which turns out to be noise dependent. So the contrast is also in some way resolution dependent. So it's not absolutely clear.
Yeah. Interesting. Thank you.
Can I just come back to the question for a moment? I look at your last slide. This is something that I find very fascinating, because knowing what the radiologists think versus what the physical metrics is important. But if we look at contrast on the top right, the UTR is right at the bottom. Yet if we go to, if contrast is that important, go to overall image quality, and UTR is doing okay.
Maybe it's because within the uncertainty, it's not that far from each other. And, maybe
I
that's...
think most of them are not statistics.
Okay, right. Thanks a lot.
Okay, again, about the machine learning part and the denoising. I mean, if you, in the moment you train with high dose, low dose pairs, so probably if you go for patients, you will not be able to increase your training data because you will not have high dose, right? There are also denoising strategies using pairs of low dose, and depending on what kind of noise you have, they also show that they even outperform the high dose, low dose training. So you just could split the data into two reconstructions of different projections and train with that. So I would be very curious how your network would perform with this. Yeah, and I'm a bit curious. So you apply the denoising on the raw projection or after the phase retrieval?
No, we applied it to the reconstructed slices.
Ah, okay.
And maybe I should clarify that we applied them to the scans, which were never used in the training. So the system.
Yeah, no, I understand that. Yeah.
Which we use for inference, for denoising.
I would. No, I understand that. I thought maybe that you can improve by further train, but you will not get more training data from the patients because you have no high dose data. So, and in case if you would do low dose training, you can also improve the training because you will get more data over time. So just one point. There are a lot of discussions. What would be the best position for the denoising? If you do it in the projection space, in the xenogram space, in the reconstruction space. And I'm also wondering how the phase retrieval with all the low pass filtering affects the efficiency of your denoising. So maybe you should also check in which position and of the pipeline you place the denoising part.
That's certainly very, very relevant. One thing which we are planning to do at the next stage is to compare the effect of denoising with and without phase contrast. So we want to check the combination of AI denoising and phase contrast, because currently our sort of claim is that we improve things by phase contrast, and then we improve it even further with denoising. But maybe denoising is so good that we no longer need phase contrast. We can just
Or the denoising basically would apply the phase retrieval as well. So we could basically train the transition, put it in the network as well, maybe.
I've seen many papers where people use AI for phase retrieval.
Yes, exactly.
Honestly, I hate it.
Yeah, okay.
Because first of all, it's absolutely unnecessary. This Paganian's method is so simple, fast, and efficient that you don't need anything fancy to replace. No demonstration of the need to do so. And secondly, I don't think you can do a correct phase retrieval by denoising. It's just I don't know. You would be trying to predict something.
No, just maybe you understand better what noise is and what the effect of the phase retrieval is doing to the noise if you have it in
so
one pipe.
That's what we're going to try. Yeah.
Well, thank you, Tim and Amir, for that excellent presentation. Indeed, that work, it's... Oh, yeah, thank you. Yeah. Thank you, Magdalene. Certainly the output from part one of the project is really tremendous. Like it's covering lots of different elements so that we can prepare ourselves for this clinical trial. And indeed, we didn't even discuss, but the first part of the work that Amir presented was, as far as I'm aware, the first ROC analysis that shows that that phase contrast CT may actually be improving the quality compared with conventional mammography. So I think that's certainly congratulations there, and it's justifying the next move towards the clinical trial. So I think the outputs on part one are tremendous. So moving on to, if I may, the second project. And in a way, this is the most courageous part of the study, because this is trying to create a clinical environment here at the synchrotron to be able to actually image patients or image women in 2025. So it gives me great pleasure to invite Dr. Daniel Hauserman to the stage, along with Dr. Jane Fox and Dr. Dania Abu Awad. I just...
All right, so I'll be talking about project 2. So as Patrick has said, we're consisting of Jane, Daniel, Sarah, and myself. And building on to what project 1 is doing, our main aim is getting everything ready for hopefully a clinical trial in the near future. So we've started off with initially testing out the space to check whether it's comfortable or not, because obviously if we're going to scan women in the future, it needs to be comfortable and it needs to be inviting. So in this video here, we have Jenna, our PhD student, spinning around. So the aim is to have the breast to remain in the axis. So we had, in the beginning of this year, we had volunteers come in and test out the bed, give us their opinion on how they feel. We also gave them surveys before they went on the bed, afterwards, to assess how their nervousness or their anxiety at baseline, their anxiety throughout different speeds. Because as was mentioned previously in the Q&A, we can't have the bed spinning too fast. So we tried different speeds to see how people are feeling and assessing their nausea and anxiety. And so essentially, the good news is that at the different speeds, the nausea and anxiety was relatively the same. There was no significant differences between the different speeds. And if there was, it was very minor, because if we look at speed, for example, the range was, the scale we used was 0 to 20. So 20 was at high nausea. The average at the highest speed was 4. So that was, even though that one did have a slightly significant difference, 4 was still considered no nausea. So it's a speed that we can use. One of the things to note is that we did have women spinning one after the other. So by the time they got to the fastest speed, they were spinning for 3 rounds at that stage. So it probably will work well clinically. And then in terms of anxiety, it remained low at all speeds. The main thing that most people would say is the direction of the spinning can sometimes make them feel a bit uncomfortable. So we trialed closing their eyes, opening their eyes, and there was quite a bit of variability on what people preferred. So some people found it worse if they had their eyes open. Some people found it worse if their eyes were closed. And this was especially the case for women who were wearing glasses. So closing their eyes was better for them. But overall, most people said it was comfortable. The ones that didn't said they'll still do it anyway. It was better than mammograms, so that's a +1. That was our first initial test. So the next stages will be getting the machine ready for real scanning. But in terms of comfort, we did have to make some adjustments to the bed. We had to get clinical grade equipment, so stairs, proper stairs to go up because the bed's quite high up on a platform. We tried out different cup sizes and we settled on specific sizes that we can use to encompass all women. And we're also planning to properly shoot a video to show women the experience from reception to the scan, just because it is a new experience. So we're hopefully going to record that in the next month or two as part of our educational resources for volunteers that are eventually going to be scanned. We are going to be starting off with patients that have no breast cancer first, and hopefully doing that in the next year. On the imaging side of things, we've introduced the scan jitter correction to eliminate associated artifacts and improve detect the gap fill in images with deep neural networks. And in terms of scanning, again, so throughout the year, we've scanned mastectomy samples thanks to Jane, and we've done a full clinical rehearsal. And it helped us to clear up issues with data collection, processing, imaging, quality. We use breast phantoms and mastectomies, different energies, dose, detector settings that me and Tim have talked about as well. So essentially, we scanned at the full settings that we would scan on real patients. So that all the pre-operational testing is completed, and now we're just working on a report to submit to ANSTO for approval to then use in the clinical trial. And then on the dose side of things, we tested the reproducibility of the scans, performing 63 clinical rehearsals over 18 months over the past year, and using, again, the scan parameters for the human volunteers. And we had 13 measurements made in identical setups with the same pharma chamber, and it gave an average dose rate to air of 0.31 with a standard deviation of 0.06. So Alex, I'm not sure if most of you might know her, developed the first Monte Carlo simulation to model the BCT patient breast glandular dose for patients with different breast sizes and density, thus opening the door to customized imaging based on the patient's breast clinical specifications. So the next steps are getting approval to scan real patients with radiation. So we've finished a pre-operational testing. We need to just get all the approvals done, getting all the ethical aspects to, again, scan patients, all the educational resources, and hopefully we'll be scanning the first cohort next year. And we'll be publishing the comfort testing results soon as well. So if you do have any questions, Daniel will help answer any questions on the scanning parameters. I do apologize about the noise in the corner throughout other talks, but yeah. Whenever he's sorry, yes. I struggle with it as well, but any questions? Yeah.
Thank you. I am just kind of curious about what is the, I guess, like, immediate goal when you start getting patients in, like, who are the people that are going to be come in to the synchrotron to actually get the breast CT done here? And what is the kind of plan for the variety of people that you can image in terms of like weight or ability to even get on the stage or age? Like how are we planning to get elderly people on the stage and stuff like that, for example?
Yeah, so yeah, that's a great point, because we are going to aim to stick to women that would have had mammograms. So from age 50 onwards, we do want them to have a recent mammogram with clear results, so within this past 6 months. So kind of back to what me and Tim were talking. So with the normal cohort, for example, we are going to have women who've had a mammogram and it was cleared, so that when we do a scan, we're expecting to find no new cancers there. And once we do the cancer cohort, we'll be able to, if they we need to have the full results, biopsy results on what cancer type they have in the location, and scanning them before they have any treatments, and then correlate the scan with the mammogram. So that's the most important thing. In terms of yes, ability to go onto the bed, we will have to have a checklist of whether or not they'll be able to go up the stairs, for example, and lying down isn't going to be too long. I don't know if you've had like a MRI, for example, but it is quite a breast MRI. They have to lie prone for this as well. They have to lie prone. This will be shorter though. So we will have to ask them questions about nausea and things like that before motion sickness, before we let them, I guess before they consent to coming in to begin with. So there are going to be lots of checks that we have to do to make sure it's safe for them and they can tolerate the scan. But all up, the spinning itself is not quite long. And it is better than a mammogram, so that's again our main plus. But in terms of sizes as well, like we're working with Alette and as well, so we can't do at this moment really small breasts on really large breasts. So we're trying to aim for the average, just to get the parameters set up well on average patients before we expand out further.
Just a curiosity, are there going to be like radiographers or nursing staff or something like that looking after the patients?
Yes. So for the actual day, we will have a nurse helping out and radiographers helping out. For the comfort test, we've had radiographers help out. So we have quite a few that are familiar with the machine at the moment. And that was been really important, because when we speak with Daniel and his team, there's factors like such a breath hold that we are very used to doing clinically and very used to on how to explain the radiation and the machine to patients. So definitely going to need to have that to explain it to a patient level, while we have all the engineers and physicists at the back. So absolutely, yes. And then obviously we'll have the images reviewed by radiologists as well.
Thank you, Daniel. Thank you, Daniel and Jane. I think this is really very fascinating to be able to transition this place to a clinical imaging facility. Is taking a huge amount of work. I presented some of the early work around the comfort testing. That is actually Jenna's PhD, and you know the look on the faces of clinicians about the fact you are going to be spinning patients around with a stationary X-ray beam to create CT images was really very interesting. You know, so I think that to be able to actually show that this isn't going to create excessive discomfort, and I think it was very encouraging to show both for the anxiety, but particularly for the motion sickness, that the level of discomfort from that scale to 0 to 20 was way down around 2 and 4 at the most. Yeah. Okay, any other questions? I think the other element of this work that Dania is doing is also preparing the radiologist and preparing patients for this environment. And Daniel's been critical on this in terms of the environment. We can't just simply walk patients into a cold synchrotron unit and expect them to be comfortable. You know, so there's been a huge amount of work making this place really comfortable and enticing and welcoming for women. So I think, you know, it's another arm of this work that we don't perhaps give full credit to, because there's a huge amount of work there. But also preparing radiologists. These are new images. You know, if you put me into a Ferrari, I will not drive it as well as I do my Toyota, because I'm not used to driving a Ferrari. Whereas radiologists have to become familiar these images as well. So there's a whole load of preparatory work there that I know Amir and Danya are leading. So thank you very much. So the good news now, it's tea time and we're close to time, I think. So if we can come back here perhaps at just at 11:10, that would be good. Thank you. Okay, well, welcome back. And it really gives me great pleasure to welcome our second guest note speaker, Dr. Mara Tanuti. And I think we should all be very grateful to Dr. Tanuti because she was supposed to be doing a joint session with her colleague, Dr. Maria Kova, but unfortunately, Maria broke a bone last week at the last minute, and two legs, both broke both legs. So unfortunately, couldn't make it. So Mara is here on her own to deliver this talk. So thank you, Mara. I'll just tell you a little bit about Mara. She's head of the breast diagnostic section and reference radiology for the breast unit of the University Hospital of Trieste, Italy. She is the regional mammographic screening coordinator, and indeed Mara and I are working on another project looking at the performance of radiologists in that part of Italy around breast screening mammography. She has collaborated on the SEAM project involving synchrotron light mammography and conducted an observational study on volunteer patients undergoing this technique. She was member of the CERMA CT research project for the development of phase contrast tomographic examinations of the breast, principal investigator of the international clinical trial MYPEBS, which is the randomized comparison of risk stratified versus standard breast cancer screening. So it gives me great pleasure to invite Dr. Tanuti here to talk about advancements in breast imaging diagnostics.
Thank you. Oh, put this here. I don't have a second. Okay. Yours. This don't stay here. Okay. 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 Good morning. You hear me? Yes. Good morning, everyone. It's a pleasure for me to be here, and I thank you for the invitation. Even if I'm very sorry because Professor Maria Kova was supposed to be with me, but for health reason, she couldn't come. And so I bring you her greetings. So I will speak for her, and I apologize in advance for my poor English. As you know, every year more than 2 million women worldwide are diagnosed with breast cancer. In Europe, breast cancer is the most frequently occurring cancer, not only among women, but overall, with more than 500,000 new diagnoses annually. It is estimated that about 13% of women will be diagnosed with this disease during their lifetime. Women over the age of 50 are most frequently affected. However, the global incidence of breast cancer has still increased in recent years across all age groups. Improvement in the diagnosis and treatment of breast cancer have led to a significant reduction in mortality. Nevertheless, it remains a major concern because approximately 3% of women are estimated to die from this disease. In 2020, the estimated number of deaths from breast cancer in Europe was around 140,000 women. As you can see from this WHO map, Australia is also among the countries with the highest incidence of breast cancer, like almost all European and North American countries. For the diagnosis of breast cancer, we have several technologies available. In this presentation, I will focus on the youngest technologies, if we can say so. So then we will look at mammography with contrast medium, breast CT, and imaging with microwaves. So contrast enhanced mammography is a full field digital mammography that involves the use of endovenous iodine contrast medium. Following the injection of an iodinated contrast agent, images are required in a rapid succession at a low energy and high energy. The high energy images are then processed through a subtraction or recombination mechanism. This process generates 8 images. 2 pairs of low energy images and 2 pairs of post-contrast recombined images for each of the 2 standard breast views. The examination can be supplemented with tomosynthesis. The visualization of the contrast agents lasts about 10 minutes. Image acquisition begins approximately 2 minutes after the injection of contrast medium and ideally continues for an interval between 2 and 8 minutes. In certain cases, late phase imaging from 7 to 9 minutes after injection can be useful for better characterizing specific tumor types like lobular carcinoma. The reporting follows a standardized lexicon similar to the BI-RADS already used for other breast imaging modalities. The report is generally divided into 2 main sections. In the low energy images that are very, very similar to a 2D mammogram are evaluated breast density according to the BI-RADS criteria and the presence of any suspicious calcification, masses, or distortion. In the post-contrast recombined images, which highlight areas of enhancement, are evaluated BPA, background parenchymal enhancement, according to the BI-RADS scale, especially whether it is symmetrical or asymmetrical in the 2 breasts, and the presence of mass or no mass enhancement. This is an example. This is a patient from our breast center in Trieste. This is the first one last year. As you can see in this low energy imaging, we can see a small and round a small opacity about 10 millimeters in the internal quadrant of the right breast, which correspond in the post-contrast recombined images to a mass-like enhancement area with lobulated contours. The diagnosis was infiltrating ductal carcinoma non-special type. In these images taken from the literature, we can see better how the lesion, not visible at all in the mammogram, is clearly visible in recombined post-contrast images in this very high density mammary gland. Also in this case was invasive ductal carcinoma. Comparing contrast enhancement mammography and full field digital mammography, the radiation dose of CM is about 30% higher than that of full field digital mammography alone, but was comparable to the dose of DBT, digital breast tomosynthesis. And it is lower in dense breast compared to non-dense breast. As for image quality, high energy images are considered non-diagnostic and that therefore not to read. Low energy images are required with parameters similar to those of standard mammography images, ensuring comparable diagnostic quality. In the recombined or subtracted images, tissues without enhancement are characterized by neutral gray tones, on which areas of enhancement are even more prominent. What are the indications of CM? The most common indication is as an alternative to magnetic resonance imaging in breast cancer detection. MRI has slightly higher sensitivity, 97% versus 91%, but CM still offers higher sensitivity compared to non-contrast imaging modalities like mammography or DBT. Additionally, CM has a specificity of 74%, slightly higher than MRI. Another indication is as a problem-solving tool, for example, in cases of indeterminate lesion or calcification or in dense breast. Also, is in preoperative local regional staging as an additional diagnostic method, it can significantly influence surgical planning, altering it in about 18% of cases. However, MRI may remain still more sensitive in case of occult lesion. Also, in evaluating the response of neoadjuvant therapy in the follow-up of post-treatment, and this is an interesting tool as a guide for biopsy. It offers diagnostic accuracy similar to MRI-guided biopsy, but with the advantage of greater accessibility and shorter procedure times, about 15 minutes, which is far less than MRI-guided biopsy. Also, is useful in the evaluation of symptomatic breast, for example, palpable masses or visible changes with a sensitivity of 97% in dense breast and diagnostic performance comparable to ultrasound in symptomatic women. And the preoperative evaluation of patients with breast implants. Future direction for CM are some emerging indications, see CM being used as a screening method for patients with dense breast and intermediate lifetime risk, as well as in screening recalls, where it can improve sensitivity and specificity in diagnostic evaluation, reducing the biopsy rate. The data currently available on CM have some limitations, since most of them come from retrospective studies. Therefore, prospective studies are needed to evaluate its performance. CM is still a relatively underused method due to the risks associated with the use of iodinated contrast agents, the same with breast CT, and increased exposure to ionizing radiation. But a lot of clinical trials are ongoing, prospective trials such as contrast enhanced mammography imaging screening trials, CMIS, by American College of Radiology, whose results may positively influence the perception of CM's validity and promote its wider adoption. Breast CT. You know everything about this, I think. This is an X-ray technology that allows the acquisition of multiple cross-sectional images of the breast and provides a complete and three-dimensional view of the breast tissue without compressing the breast. The examination is performed with the patient in a prone position on a dedicated table with an opening, with a hole where the breast is accommodated. No compression is required. The duration of the examination is about 10-15 minutes for breast, and the use of contrast medium is optional. Currently, most breast CT systems use cone beam technology, in which the X-ray tube and detector rotate around the breast in a single circular motion, capturing a cone-shaped X-ray beam that covers the entire area of the breast in a single rotation. So a series of 2D images generated from different angles and then reconstructed by a software into a 3D image. The breast tissue is analyzed in thin slices, improving the detection of small lesions such as nodules or microcalcification, and also providing a detailed view of the structures of the breast, including the milk ducts and fibroadipose tissue. Another system currently in use is the spiral breast CT with photon counting detector, in which the X-ray tube moves in a helical spiral pattern around the breast. The photon counting detector improves image quality because it offers higher resolution, reduced image artifacts, increases the contrast between different types of tissue, even at low radiation dose, thanks to its superior dose efficiency, by identifying multiple energy levels. It potentially makes the use of contrast medium unnecessary. The ionizing radiation dose of breast CT without contrast medium is generally comparable to that of a diagnostic mammography. Moreover, only the breast is involved in the scan. As for the breast coverage, the lower and posterior regions are better studied compared to traditional mammography, while coverage of the axillary area may in some cases be limited. What advantages does it offer? Higher spatial resolution, greater comfort for the patient since there is no need for breast compression, Although the prone position may cause discomfort to the neck and shoulders, three-dimensional images of the breast and the possibility of using contrast agents. What are the clinical applications? In lesion detection, it shows high sensitivity even without the use of contrast medium. As for the diagnostic accuracy, it has higher sensitivity than standard mammography and diagnostic performance comparable to that of MRI. However, there are some issues such as the exposure to ionizing radiation and side effects from iodinated contrast medium, like from CM. In lesion size assessment, its performance is comparable to that of other methods, with the better accuracy in non-mass enhancement lesion. However, there may be histopathological radiological size discrepancy, especially in larger or bigger lesions. In evaluating the integrity of breast implants, it is capable of identifying intracapsular ruptures and other complications. It can also be used as a guide for interventional procedures, ensuring reduced execution time compared to stereotactic guided procedures. These are some examples taken from the literature to show the better sensitivity of breast CT in comparison to that of the standard mammography. In the case A, mammography show no evidence of disease. However, in the pre and post contrast breast CT images demonstrate a small mass, which is pathological, confirmed as an invasive ductal carcinoma. In case B, this is a dense breast type C, BI-RADS C for density. The mass is missed or near missed, and it's correctly identified on non-contrast breast CT due to the lack of tissue overlap and relative higher CT attenuation than surrounding parenchyma. And contrast enhanced breast CT further displays it more clearly. In case C, this is a breast with a higher density, BI-RADS D in density. We can see the mass is almost completely obscured on mammography and even on non-contrast breast CT. The lesion appears very well in a contrast CT. This is the technology for spiral breast CT with a photon counting detector developed by Advanced Breast CT, a German company. And now we come to breast imaging with microwaves. That is an Italian technology that has appeared in the last 4 years. I suppose this audience know what are microwaves. Microwave breast imaging use low power electromagnetic waves that are transmitted by 2 antennas during breast scan and interacting with the breast tissue. This method leverages the differences in dielectric properties, such as permittivity, between healthy and tumor tissue in the breast. The scattered signals are captured and sent to a processing system with an algorithm that analyzes this signal to create a detailed image of the breast tissue. The resulting images are intensity maps, representing the homogeneity of the dielectric property of the tissue. The system incorporates AI to improve the accuracy of lesion detection. During the examination, like for breast CT, the patient is in a prone position on a table, and each breast is accommodated in a soft cup with no need for compression or the use of gels or liquids. Furthermore, there is no ionizing radiation, making this method suitable for repeated screening for women of all ages, including younger women as well as pregnant women. And of course, microwaves do not hit the breast. MammoWave is a diagnostic device for microwave breast imaging developed by UBT, Umbria Bioengineering Technologies, an Italian company specialized in medical technologies. This device has been used in various clinical trials, both in Italy and in Europe, which have demonstrated its effectiveness in breast cancer screening. In particular, this article, published in 2023, discusses a multi-centric prospective single-arm clinical study conducted between 2020 and 2021 that involved 353 women with an average age of 51 years, with the goal of assessing MammaWave's ability to distinguish between breasts without radiological findings and those with findings, including both benign and malignant lesions. The results of the MammaWave scans were compared with the standard radiological reference, including histological examination when available, and the results are promising. MammaWave demonstrated sensitivity about 82% for lesion detection, with a specificity of about 50% in line with the expectation. Now, a prospective study, multi-center study, MammoScreen, is currently underway in Europe, and that will end in 2026 to evaluate the diagnostic accuracy of this imaging, recruiting 10,000 women, and also our breast unit in Trieste will participate. And that is all. Thank you.
Thank you very much, Dr. Tenuti. Have we any questions, Barb? Yes, good. Thank you.
Thanks heaps, great talk. I just was wondering, do you think microwave imaging is going to be the future of breast screening and it'll just put x-rays in the bin? Or
No, I think it's not the future of breast screening, but I think it's very interesting for the younger population from 20 to 35 years, not at any risk, familiar or genetic risk, that now for these young women, we don't nothing. So I think this is a good technology, more accuracy of palpation of a visit, and can screening about nothing or a dub of a lesion. Not for screening the women of from 50 to 74 years. I think this is not the case of.
I may have missed it, but for the microwave imaging, is it similar to nuclear imaging where it's functional data rather than anatomy?
Can you put the microphone? Sorry.
Oh, sorry. Is microwave imaging similar to nuclear imaging where it's more functional data rather than anatomy?
No. Nuclear medicine use radioactive components. So in this case, we don't use any pharmacal.
Yes. But for the image at the end, the information that you're getting, is it anatomy based or is it functional based?
Not functional, no. The maps of dielectric properties. Cioè non è funzionale come medicina nucleare, fa una mappa del segnale elettrico.
So it's not a functional, so maps basically this electric signal inside the tissue.
But will radiologists be looking at numbers or images?
Numbers, a map, not image. A data, a number.
Again, thank you for that. Now, one of the we often see MRI as the gold standard in terms of sensitivity with breast cancer, and I see that with the CT it's getting close to. But one of the downsides of MRI is low specificity. Do we have the same issue with CT? With the CT? Yeah.
I don't have an experience.
Yes. Okay.
And I think that CT with contrast medium has a better accuracy than CT without contrast. I don't know about, you have to see with a study, prospective studies, you know, compare breast CT and MRI.
Okay, fine. I think there was another very important point, if I may. Yeah, another very important point you raised was with the CEM data that was from Dr. Rue Pineapple's group. You showed that there needed to be a minimum read of 200 CEMs per year to be able to function well. And I think that's a lesson for us. And certainly some of Amir's early work with the ROC would show that the abilities of clinicians very much depends on their experiences. So it's something I think we need to consider with this work is with phase contrast, do we not need to start thinking about minimum reads per year?
A learning curve.
Yeah, yes, correct.
But I think that AI do it better in the future.
Just a comment to the specificity. So we did the study with the Koning system, which is not really the latest technology, I think 5 years ago, and in comparison with breast MRI. And they showed that in combination with contrast agent, the specificity was similar to MRI, to breast MRI, but without NOT. But
yeah, no?
Yeah.
For CM, no, the specificity is not so higher. Not, CM has better specificity than MRI.
Yeah, just saying that we did that 5 or 6 years ago with an outdated, I would say now outdated breast CT system, the one from Koning. So there's also no photon counting and something like that inside. And there was the discussion, should we go for MRI, for breast MRI or for breast CT? And they said that in combination with contrast agent is more or less the same specificity, but without it was not as good as the MRI. Just don't know.
Sorry, I have a quick, maybe silly question. In one of the first slides, you showed the statistics that breast cancer is now the most frequent cancer, and in both sexes. And I seen that quote before. I just wonder, does it include skin cancer?
Is the more frequent cancer in worldwide worldwide in yes, yes. Is the most frequent.
More frequent than skin cancers?
Yes.
Wow.
Sì, no, sì, è più frequente.
It's the most frequent. It's
The most frequent.
above the skin cancer.
Thank you.
So again, thank you very much, Dr. Sue. All right. Well, then now it gives me great pleasure to move to project 3 of the work, which is really again a hugely important part of the study because we can't in the long term we can't think about X-raying patients with the synchrotron unit. We've got to think about compact sources for our patients. So Professor Marcus Kitchen, the University of Monash, is going to give us some findings.
Thank you, Patrick. Yeah, great. Well, thanks for having us here today. So Project 3, as Patrick said, is trying to do mammography on a compact X-ray source. This project is probably the least advanced of all the projects, partly because we haven't had anyone staffing it apart from myself. But I am now pleased to introduce Dr. Michelle Crowan, who is our new postdoc for the team. She's going to be presenting some of the work that she's done in the last few months. She only joined us in May. So we're looking forward to finally progressing quickly with this project now that Michelle's joined the team. So this is just a photograph of my lab. So we have here a microfocus X-ray source from X-ray Works in Germany. It can produce focal spot size of around 6 micron up to about 50 micron with power from basically close to 0 up to 50 watts. So that's nothing compared to a standard X-ray source that might produce kilowatts of power. So we don't have a huge amount of power, but what we do have is high coherence, and that allows us to do phase contrast imaging. At the moment, we're focused on propagation-based phase contrast. So our X-ray beam comes along here. We have about almost 3 meters from the end of the source up to our detector at the back here. And so we can, of course, change that, and we can alter our magnification anywhere from roughly 1 up to about 45 times there. So we can get quite variable resolution for our system. We can also use different targets and different filter combinations here. So unlike mammography, which might use a molybdenum target, for example, at the moment we're using a silver target. Silver can melt relatively quickly, so we're sort of limited between sort of 10 and 20 watts of power at the moment. So that makes our exposure times a little bit long. We also have tungsten targets, so we can get up to that 50 watts of power for a higher energy spectrum as we move towards full breast imaging. So we are currently focusing on 2 possible projects kind of simultaneously. One is for full mastectomy samples or full breast imaging. We haven't got that far yet. We're starting off with smaller samples for potentially lumpectomy imaging for hopefully helping with surgery to detect whether or not all the cancers have been removed during surgery. We may move to other phase contrast techniques in the future, but for now we're starting with propagation-based imaging, and we can just move our source and object around. And we have a rotation stage here for doing cone beam CT. We also have a couple of options in detectors. So at the front here we have a Hamamatsu CMOS detector, which is a standard dental unit with 50 micron pixels with cesium iodide scintillator. But we also have down the back here our photon counting detector, which is a Medipix 3 detector with 55 micron pixels. So we've heard a lot about photon counting detectors today and the benefits that they can provide. We've also heard some of the challenges of them as well with charge sharing problems, for example. This does have a charge sharing correction mode. It also has 2 energy thresholds. So we can do dual energy, but without charge sharing at the same time. So certainly very interested to try some of the things we've heard today about material decomposition with this technology, and also to see how much lower we can get in terms of dose compared to this. But there are a few more ugly sides of photon counting detectors. They're not the most stable technology around, so you really need relatively short exposure times, and Michelle will show you some of the challenges there. But what have we achieved sort of before Michelle came along? We've set up the laboratory a couple of years ago, and we're making a lot of improvements to it along the way. Our PhD student, James Pollock, has done an amazing job putting together our control system. He's written this CT GUI here. Actually, it's not just a CT GUI, but it does all the control and alignment for all of our stages and allows us to take our data in synchronization with our detection system. We also can do dosimetry as well, all at the same time. So without further ado, I'm going to let Michelle tell you about what she's achieved.
Oops.
You don't want my phone? Have that instead.
Thanks. Hey everyone. Yes, so I'm new. I've been around for about 6 months, so this project is still a little bit of a baby, so I don't have anything as impressive as you've seen earlier today's show, but I'm just going to kind of go through what we've been doing in the lab so far. So as Marcus had said, using photon counting detectors has kind of a couple of issues with it, but we're slowly working our way through them. For example, we often see this sand dune noise across the detector, and one of the challenges with this is that it will shift or strengthen slowly with exposure to X-rays. And so if we're doing long scans or even over the order of say like 10 minutes, this can really interfere with the quality of the images that we get. We also have sensor chip gaps. So you can see there's 2x5 chips here, and the gaps between them are filled up with slightly larger pixels than normal. And these pixels have a different response curve to the other pixels in the detector, so they have to be dealt with separately. And we also have a lot of misbehaving pixels within our detector, such as dead pixels, hot pixels. We get cosmic rays coming through and adding counts to our pixels. And we also have found that we have a lot of these fluctuating pixels that will kind of oscillate in their response based on the intensity on them. And you can see in this plot here, I've got like a normal pixel in black as we're doing one of our CT scans, and you can see it's got a normal amount of noise on it. And then we have our bad fluctuating red pixel that is varying by thousands of counts. And so we've had to go through a process of figuring out how to highlight all of these misbehaving pixels and remove them for our data before we can do our reconstruction. So to start off with some of the stuff that we've been doing is just doing some testing with phantoms. So this is one of the phantoms we're using here. The main cylinder is made out of PMA, and we've got some tissue and bone equivalent plastics. And what we're doing with this is we're assessing, we're doing CT scans at different distances from the source, but at the same magnification. So the synchrotron, the magnification is really, really low, so you can just do whatever propagation distance you want from your sample to your detector. But here we kind of need to manage the geometry of our setup so that we make sure our parameters are kind of consistent between the scans. So what this means is that as we move our sample further away from our source, we get less and less X-ray photons, and so we get less dose, but it also means that the noise in our images increases. But it also means that we can get more propagation distance, which means we can do our phase contrast imaging and do phase retrieval in our scans to reduce the noise. So for this first test, we kept our magnification the same, and we're just seeing how does the noise change as we increase our propagation distance, and then how well can phase retrieval improve that. So these are some of our slices from that sample at different distances. So the first column is the closest distance we did, and then an intermediate distance, and then a much further distance. You can see as we increase the distance, less X-rays, more noise in the reconstruction. And then when we do the phase retrieval on them, it really improves the results. And even in our far distance CT scan, we can resolve this tissue equivalent plastic here compared to the PMMA, which we couldn't really do in the non-phase retrieved images. So this is really great that we can do this. So I've kind of got a plot here where we've got the contrast to noise on the y-axis and then the distance that we image the sample here. The brown or like orange plots are for the non-phase retrieved data, and then the blue is for the data that we've done the phase retrieval on. So we can see at all distances, applying phase retrieval reduces the noise in the scan, and then increases our contrast to noise ratio, which is great. And we can see that the difference between the contrast and noise between the closer distance and the further distance is between maybe like 5 and 3. So it's not like a huge reduction, but I want to highlight that scan 5 at the most right here, this has 3% of the flux of the first scan on the plot there. So really huge reduction in dose and only a small reduction in the contrast to noise ratio, which is pretty exciting for us. So if I was going to image a patient, I would be aiming to do a really long propagation distance as possible in the lab to reduce the dose but maintain image quality. But if I was imaging a sample, I would do that as close as possible to get the best contrast to noise ratio as we can. The next thing we did is collaborated with some people, Roger Byrne, who does prostate cancer work, and he's been able to send us some prostate tissue. And so we've done some imaging with this. The goal of this is to just show that with our system, we can see different types of tissue within a sample. And so this is some of the reconstructions for this particular sample. We had much higher detector counts for this particular sample, and we found that these reconstructions resulted in really bad ring artifacts. A colleague of mine, Linda Croton, was able to help us with that and applied some ring correction, and it's really helped. And this is a great result for us here because it shows us that we can differentiate between different tissue, types of tissue within a sample with our system, which is really awesome. Some other stuff that I was working on during my PhD was image deblurring, and I've been also working on that in conjunction with this project to kind of see if we can help improve some of the results we get with not the photon counting detector, but if we use the Hamamatsu detector. And this is just some data of a mouse lung. And so on the left, this is the original blurred image, and on the right, we've applied some deblurring to it, and you can see that the speckle from the alveoli is much sharper. And this was done in collaboration with Dom, who's also working for us at Monash. And so this is very cool. And this is just kind of our goals going forward. So as I said, we're still in the baby phase of our project, so we've got big aspirations, and hopefully next workshop we'll be able to update you on what's in these.
Thank you very much, Marcus, Michelle. Any questions?
Thank you very much. I have a question to the deep blurring. What is the training, and how do you get the ground truth, the non-blurred image?
Sorry, can you repeat that? I didn't quite.
You said you apply deep learning for the deep blurring. No, not. Okay, sorry. And then
this is an AI or machine learning.
Yes.
So I've developed a different kind of deconvolution algorithm to deblur the images based on a point spread function that we measure for the imaging system.
Thank you.
Yeah, thanks for the talk. And it's interesting to look at the optimization of propagation distance where you don't care about the dose. You at the end of the day, the shortest is the better, which is kind of counterintuitive since here we're a community of propagation based. In that case, more propagation is not better, it's worse. In terms of absolute quantity, there's another parameter that makes a big difference in terms of the effectiveness of phase retrieval, which is magnification. Have you tried also to do a study of different magnifications given a system dimension?
No, we haven't. I'm aware that if you have higher magnification, the phase retrieval should prove better as you increase your propagation distance. I know if you have low magnification, you have less phase retrieval, and you'll see less improvement, and so you have more noise with higher propagation distances, but we've only done the one magnification. It was 2.2, but we haven't tried others yet.
Okay, thank you.
I think obviously this is a hugely important project, getting these light sources down to a level which could be implementable within the clinic. But when I hear about 50 watts, it worries me a little, Like how many years are we away from having something that could actually work in the clinic, do you think?
Thank you. Yeah, great question there, Patrick. So certainly our aim is to be able to ultimately do scans in tens of seconds. I guess we said this as two projects. We're hoping at least for the lumpectomy that we could do it in sort of 5 minutes or something. It's a bit more realistic. With our source at the moment, I don't think we're going to be probably able to get a 20-second scan with it. But I think what we're really doing is optimizing phase contrast to see if you had a much better source, like a liquid metal jet, which we do have one of those at Monash, and as better compact light sources come online, we'll learn sort of what is that power time trade-off. And so eventually we'll say, if we wanted to do it in 20 seconds, we're going to need a source that produces 200 watts, 500 watts, that sort of thing. So it's about learning rather than necessarily having a product ready to go, product, I should say, in the end. So, but we'll know what needs to be done. Tim?
Sure. I just wanted to ask about the detector, the number of those fluctuating pixels. It's kind of looks worrying, and also maybe it's related to this very severe ring artifacts that you showed. Does the detector perform according to the specs, or can you do anything about reducing that kind of bad behavior?
I think if I was to guess, I would say there would be on order maybe 100 or so of these fluctuating pixels on the detector, which is a really small fraction of the total number of pixels. In terms of the artifacts they create, if you think of like what like a Zinger artifact looks like in a CT reconstruction, it's kind of like a 1 pixel line kind of striped through your artifact. As these, if you are on a slice that has one of these pixels and it fluctuates in the different projections, you'll see kind of bright and dark zinging artifacts kind of going through the slice. It makes this kind of Mandela type effect through it. And masking them out and removing them removes those artifacts completely. That was the first half of your question, and I don't remember the second half.
So in terms of the specifications of the detector, we actually had a bit of a delay of about 8 months where the first detector we got had some very big regions of dead pixels, like 60 to 70 dead pixels in a patch, which they were supposed to be less than 10. So we sent it back and they, for free, fixed it for us at Advocam. And so now we have many fewer dead pixels in clusters, but there are still a number of bad pixels throughout the detector. But as Michelle said, we can, if we know which ones they are, we can at least mask them out and interpolate over them because they're generally 1 or 2 pixels wide. So it's not terrible.
Thank you. Thank you very much.
Okay. And on to project 4. And I think one of the cool things about this project is that we're actually looking at things beyond breast, looking at the versatility of this new technique. And always Professor Kay Morgan comes up with the coolest images, and Kay's work is on lung. So again, it's a great pleasure to welcome Dr. Morgan to talk about her work on lung cancer.
Thank you, Patrick. Good. So, yes, Project 4 aims to build on the successes of the mammography program and translate that to the lungs. So the lungs have always been known to create perhaps the strongest phase contrast effects of any organ in the body. But we've predominantly been looking at small animals in terms of lung research so far. So there's some challenges in then going from small animal lungs up to human-sized lungs. So the team that's working on this project is up in the board up here. So we can see across many institutions. I've just bolded our 2 newest team members from this year. So Michelle Cohen, who you just met, is based at Monash. So occasionally we might be able to borrow her for Project 4. And Lorenzo D'Amico, who was our translator for the previous talk, is a postdoc who is come from Trieste, but is also spending time at Monash and is working on the lung project. Okay, so there's two kind of key directions that we're looking at for this project. The first is looking at imaging the whole lungs to be able to identify a lung cancer, so kind of screening. And the second is in looking at some particular region of the lungs that has been identified as suspicious during a conventional scan and getting more information about that, either to determine whether it is a cancerous tumour or not, or to actually look at that tumour and determine what kind it is. So there's some that respond very well to chemo, some that respond very well to radiation, and so determining which direction to go with that. This is our timeline. So Yanis Allis began in the first year of the project with his PhD, and then Lucy Costello last year. And we started off imaging the Lungman phantom, which is a human-sized lung. We then moved last year into looking at human-sized lungs from animals, so from calves and from sheep. This year, we have welcomed Lorenzo to the project, and we've looked also at human-sized lungs with clinical comparison. So using Monash biomedical imaging, which is adjacent to the Australian synchrotron, we could image the same lungs with clinical CT and with MRI. Just this week, we're halfway through an experiment. We've been looking at the ArchiTest phantom, which allows a animal lung to be placed inside a plastic case and ventilated using a mechanical diaphragm. We've also welcomed just 2 weeks ago Johannes Thalhammer, who's visiting from the Technical University of Munich, where he's been doing research on CT reconstructions using less dose with AI. And so he'll be joining us after 6 months at Monash. We're also looking at moving into next year to taking images that we've been capturing and working more closely with radiographers and radiologists to see how these can be most useful in the clinic. So the publications that we have on the way, the first one is the images of Lungman. So we took this imaging to try and determine when we go to human sizes, we're going to need larger pixels to capture the whole chest. And we're also going to need higher X-ray energies to get through in a human-sized chest. And both of these mean that propagation-based phase effects are going to be much smaller than we would see in small animals. And so we did some imaging and we could see indeed that phase contrast is visible. You can see this kind of line around the outside of each of the features here in Lungman. You can also see that we've put some lung phantom inside Lungman here, which are difficult to see in projection, but of course much easier to see in a CT. And this is a rendering prepared by Lorenzo D'Amico, where we can see the airway tree that comes inside Lungman. We can also zoom in to see those beautifully spherical, perhaps not quite realistic, lung tumours. And one of the nice things we did see here was these tumours are designed for a particular Hounsfield unit, and to do that, they make them out of a foam. And our imaging is so good, we actually resolve the foam instead of just seeing a low density object. So Yanis is preparing the images from Lungman into a publication, looking at what is the right energy and sample to detector distance to be doing this kind of imaging in human-sized lungs. The second paper underway is coming from Lucy Costello. And so in this project, we're looking at imaging a small region of the lung. So using both a smaller X-ray beam and a smaller high-resolution detector, we can get the image you see here, this region of interest, phase contrast CT, by just passing that beam through a small portion of the lung. And so that idea would be if we see something suspicious, we can then zoom in. And so Nigel Sommerfeld has been telling us that there's work looking at the texture of tumours in lung images to determine which kind of therapy to pursue. And so we hope that having these kind of images will also be able to allow us to identify what type of cancer may be present. And you can see here these kind of individual alveoli or air sacs in the lungs. This is challenging to do this kind of imaging. So in a conventional CT, we can see the whole object and there's air on both sides. And even looking at this, you can kind of use your brain to do the reconstruction that goes from the projections that we see on the top half down to the CT slices that we see on the bottom half. When we have just this tiny beam going through a tiny portion of the lung, our projections look something like this instead. So we see that the intensity changes a lot depending if we're looking through the spine or if we're just looking through mainly soft tissue. And we've got a lot of large features that are passing in front and behind of the area of the lungs that we're most interested in. Nevertheless, we can get an image of that region. And so we see on the far side there an image with phase contrast, also quite a few ring artifacts and cupping. And we see that kind of bright area around the outside because there's a lot of absorption by the rest of the body that's not within that the field of view that we're imaging. So if we add some phase retrieval going to the center and then do some extra padding to allow that attenuation to kind of fall outside our field of view, we can get images of very small areas of the lung. And so this is from Lungman with some of the lung tumours there. And so Lucy's been looking at these images to determine how much phase contrast should we use, what X-ray energy and distance. And so if we zoom into a region of interest of our region of interest, we can actually see how these images vary as we increase the distance across the top there from the sample to the detector, so increase the amount of phase contrast and also change the X-ray energy on the vertical axes. And so we can see the first column where we don't have any phase contrast is clearly the noisiest. And we see an improvement with propagation in terms of the contrast to noise ratio. And so Lucy's quantification of that has showed that we'll get the strongest phase effects and contrast to noise in the top corner here, with the green indicating the best setting. However, you might also be able to see that up there, the image is starting to get a little bit blurry. So with a large propagation distance, we have large phase contrast features and a strong phase retrieval, which then means we start to kind of blur out some detail. We also see some of that due to source size blurring. So if we measure the spatial resolution, we get that down towards this corner is going to give us a sharper image. And you can see that particularly with that porous phantom tumour. If we combine the two, we get that the optimum is somewhere around the 5 meters and 70 keV mark. So we've got some nice settings to continue onto the imaging of the animal lungs. And so this is the direction that Lucy will go next with these kind of images. The third publication is looking at the whole animal lung. So this is from a calf, so human sized. And Lorenzo's prepared this movie where we actually dive inside the data set. And it really shows you how many generations of airways we can get down, and we still are resolving the details really nicely. So he's also looking at how can we get nice images with a very low radiation dose, because we can get a very nice image with a high radiation dose, but to be clinically relevant, we need to get the dose down. Oops. And then most recently, last week, and in fact ongoing, we've had our collaborators, Juliana Tromba and Christian Dallin, have come across from Trieste and Göttingen, and they've brought Anthony, who is the breathing lung phantom. So this is the plastic case with some sheep lungs inside and a diaphragm underneath that moves up and down to make the lungs actually breathe during imaging, because that will be our next challenge, is getting such nice images with an organ that's usually moving pretty quickly. So we see the team here. The key directions that we're looking at going into next year is to publish these papers. We're also looking for feedback from more radiologists. So we're going to be presenting some work at the annual scientific meeting for leaders in lung health and respiratory science, and collaborators from medical applications of synchrotron radiation. We're looking down some dose measurements. So we've been working with the IMBL team to be able to get a measure of air coma, and also Yakov Nesterets, who's been really instrumental in running Monte Carlo simulations and getting the measurements of dose that go with the images that we're taking, and looking at how we can reduce that. Lucy and Lorenzo will also be looking at some of these images that we've got out of the clinic, clinical modalities to compare, and we'll be working more closely to see what value these images are in the clinic. And we're also looking in February to do full lung imaging in an entire animal at the Imaging Medical Beamline. I just wanted to finish by talking quickly about some parallel work that we've been doing at Monash, which is another possible avenue to pursue within this project, which is dark field imaging, where we get a signal that comes from microstructure that's smaller than we would typically see within the image, but we can capture this effect to get these kind of dark field images. And so this is the first time resolved CT dark field imaging from a beta ENaC mouse here, and we can see that one side of the lung is much brighter than the other, and that corresponds to how many and how big the air sacs in the lungs are. So we see in the red circle, there's lots of very small air sacs compared to in the yellow circle where they're quite large. And so this dark field signal we can capture with less dose because we don't have to individually resolve these air sacs, but we can get this information out. We can do it quite quickly with the technique that Ying has developed. And so we also did this imaging in a lung cancer model with mice, and compared to the healthy trace that we see in the center. So this is how the dark field signal changes through the breath. The green in the center is the healthy mouse. The blue is the lung cancer mouse. So we see a decreased signal because there's tumors present. So the proportion of the lung that is made up of healthy tissue is reduced. And we also see a reduction in how much it varies during the breath. So those air sacs aren't inflating as well, potentially from obstructions from lung cancer. And so this is an avenue we'd like to pursue. And Yannis has been working on a new method for capturing dark fields that doesn't require any gratings. So this method uses images captured at 2 energies, potentially with an energy resolving detector, and then looks at the difference in terms of the attenuation phase and dark field effects between them to be able to extract a dark field image and a sample thickness image. And so the plan is to apply this to the lungs in the coming year. But in the meantime, we've tested it out on a Berocca tablet in water. So the Berocca produces a very strong dark field signal, and we can see that as it dissolves in the dark field image much longer than we can see it in the thickness. So just an example of how quickly we can image by using this new dark field imaging technique. And also key is the fact that we don't need to have any extra optics within the system. So very experimentally simple. With that, I'd welcome questions.
Thank you very much, Kate. Any questions for Kate? In terms of this phantom, which sounds... Thank you.
In terms of this phantom, which sounds very, very interesting and realistic, is it a case that it just simply moves the diaphragm up and down, or does it actually pump air into the trachea and so on?
Yeah, it's by moving the diaphragm up and down, it changes the pressure that's in the chest cavity, so that it extends to fill that space. Yeah.
And with that, will you need to consider things like movement on sharpness and algorithms to correct for that?
Yes. Yeah, so we can do some capture the images at the correct breath point. And so Martin Donnelly has been a long time collaborator of mine of doing small animal research, and has been really important in then moving to these large animals and using custom written triggering boxes that will send a signal from the chest. So we can use like a laser off the chest to see how the chest is moving and then trigger images to that, which helps immensely with motion blur. And so, yeah, that's very helpful.
Thank you. Just a curiosity, how did you acquire the last image? Because if I got it correctly, that is dual energy, right? And then with the algorithm applied to differentiate attenuation and dark field, did you use the harmonics of the synchrotron?
Exactly. Yes.
Okay, okay.
Yes. Yes. So
We
we
didn't use and you used the two thresholds of the Eiger detector?
We did. So we had, we were using the harmonics. So I think we set it somewhere around 27 keV and then use the harmonics at 3 times that we get at IMBL. And then use the Eiger detector with a threshold to get the 2 images simultaneously.
Okay, thanks.
So single exposure dark field. Yeah.
Thanks.
Is there any role for a gas contrast agent in this work?
Possibly. So there's been a lot of work done in Europe where they've got a synchrotron beam that can give you X-ray energies that are either side of the K edge with xenon as a contrast agent. And it's kind of a unique facility there in terms of having that possibility. I've tried a little bit with contrast agents and have typically seen more success with phase contrast and dark field.
Thanks.
Just almost following on from that question, like when you're imaging the lungs, you're also going to be imaging a lot of vasculature. And how does that look on this using this technique?
So with both phase contrast and dark field imaging, the vasculature is kind of similar to all the other soft tissue so it kind of falls into the background with the fat and the muscle and that kind of thing. So Marcus Kitchen has done some work with using a contrast agent to see where the blood is going at the same time as imaging the lungs for newborn infants. But yeah.
Okay, thanks very much.
Right, well, it gives me great pleasure to welcome our next speaker, Dr. Yakov Nestoritz, who's from the CSIRO in Australia. And Yakov always amazed me with some of these incredible algorithms that he produces that makes such an impact on our images. So, thank you, Yakov.
Thank you, Patrick. Good afternoon, everyone. I just start with emphasizing how CSIRO contributes to the project. This is done by collaboration in 2 main areas. One is dose estimation, and another one, optimization of imaging conditions, image processing, and analysis. One approach which is being rolled out across the project is sample-based dose estimation. The objective here is to produce accurate dose estimations for each sample and for each scan of the sample. How is this achieved? This is achieved by analyzing and segmenting tomographic data for each sample, producing its digital copy or digital twin. This digital twin can later be used in Monte Carlo calculations to produce Kerma to dose conversion coefficients. And given experimentally measured Kerma values in the incident beam, we can accurately calculate volumetric and mean adsorbed dose in each tissue of the sample. For more technical details of the Monte Carlo calculations, I would like to refer to talk of Elliott Engels at the user meeting on Thursday. Some examples of application of this approach hopefully can be seen in Lorenz's talk at the user meeting as well. So I'll give you some quick example of using this methodology, using some historical data, mastectomy sample of particular patient. So scanned using a Xenius detector in a cylindrical bucket at that time. So this is on the left, this is one of the demographic slices of that scan, which was segmented by using material decomposition into breast, glandular, and adipose tissues. And by having these volume fractions, one can immediately calculate glandular volume, total volume, and glandularity of this particular sample, which was calculated to be about 17%. Having this digital twin or model of the sample, we can run Monte Carlo simulations to produce Kerma to gland conversion coefficients, both for individual voxels and including mean glandular dose as well. So in this case, the conversion coefficient was about 0.7. So I would like to emphasize that different scanning conditions can be applied to the same digital model of the sample. So once the model is built, one can use it many times for different imaging conditions to produce accurate estimations of the dose. So this is particularly useful in additional calculations, for example, for contrast to noise ratio calculations for a given mean glandular dose. For example, here for the slice of the model shown on the left, the corresponding map of contrast to noise ratio for unit mean glandular dose is shown for particular imaging conditions and using particular FBP CT reconstruction method. This in turn allows one to optimize, or at least try to optimize imaging conditions such as X-ray energy in order to maximize contrast to noise ratio for the same mean glandular dose. Again, one only needs single input tomographic data set to produce the digital twin, and then to use the twin to apply different configurations, different energies, and to eventually produce plots like shown on this slide with different detector configurations. So one can see slight difference in the configuration, which is called Xenius, which models or mimics the Xenius detector on the IMBL, versus Eiger configuration, which is essentially for ideal photon counting detector. So this is probably it, what I wanted to show you as an example. So if you have any questions, I'm happy to answer.
These results you showed on the last slide for the different detectors, is it possible to make these models for polychromatic sources or not?
So what do you mean? What kind of sources?
Polychromatic. Like a lab source that's polychromatic
yeah,
as opposed to monochromatic.
I think you refer to my paper from 2018. Yes, it is possible, but you need to know more information, including spectral information of your source and other parameters of your system. So all parameters of the system should be known to produce this kind of information, in addition to the digital copy of the sample. Yes.
Thank you. I was curious about the segmentations from the volume decomposition. Could you speak to the quality of those segmentations?
This was a simple material decomposition, so it was not aimed at some fancy AI-based segmentation. It was physics-based material decomposition. So it's as accurate as your data are. So given that this sample primarily consists of two components, it was possible to do this accurate material decomposition. For more complex objects, yes, you need more sophisticated segmentation methods. So AI is one of the sort of methods to achieve this goal. Yeah.
And also, I was curious about in the following slide where you show that sort of a map of CNR. How do you derive that? Is that based on?
Again, this is for particular FBP reconstruction. And for FBP reconstruction, it's possible to analytically, or to use analytical formulas for contrast to noise ratio to produce this kind of data. For other methods, it's not that simple. So you would probably need multiple simulations, reconstructions to acquire some statistics. For FBP, it's straightforward. It was published. It's quite well-known approach.
Thank you.
Yeah, just a quick curiosity. There's a bump in the Xenios CNR plot. Is due to the efficiency of the scintillator?
Yes, exactly.
To get the iodine.
Because of the KH of.
Oh, iodine. Okay, thanks.
Any other questions for Dr. Nestritz? Okay, thank you very much. Thank you.
Okay, now again, it gives me great pleasure to welcome my long-term colleague at this stage, Dr. Professor Giuliana Tromba from the Electrosynchrotron unit in Italy. Just a few words about, if I can find them, a few words about Giuliana. Giuliana has headed the Electra beamline for a number of years, and certainly it was her work looking at 2D imaging and phase contrast that was particularly led to a lot of the work that we're seeing here. And today she's going to talk about the status and potential of the new beamline at Electra with a focus on the outcomes of the lung CT feasibility study and an initial overview of the planned clinical facility and patient plan. So really very timely. Thank you.
I have no pocket, but I think I will manage. Okay. Thank you. Can you hear me? I have a lot of noise, unfortunately. Okay. Good morning to everybody. First of all, I would like to thank Patrick for organizing this nice event and invited me. It was a real pleasure here with you after so many years. So I am going to speak about the Trieste Lung City project, the ongoing project of the medical facility that we are carrying out collaboration with Christian Dulling and other. You don't hear? I didn't do anything. I don't know, maybe the phone, the volumes. Are you getting? I put this here. No. Now it is better. No, not really. I don't know. Let us do like this. Other side. Now it is better. 1, 2, 3, better? Okay. So, the Lung City project that is carried out at LETRA, collaboration with Christian and other German institutions, together with, of course, the Trieste University and the public hospital. So, going through the outline, we take overview the clinical motivation that are behind this project. The first feasibility study that is ongoing at Trieste LETRA synchrotron with big lungs, our possible experimental protocol for the human studies, and I will quickly introduce you the new beamline that is under construction in the framework of the LETRA 2.0 upgrade program. Allora, first of all, which are the clinical motivations we are thinking to address? There are two common clinical problems to be faced concerning the lung disease. One is the lung cancer. The second one is the idiopathic pulmonary fibrosis. The lung cancer is called the big killer for its high mortality rate. It's very well known. The early diagnosis and surgery is in general considered the most effective treatment, but very often symptoms appear very late. So there are several scientific evidences showing that lung cancer screening based on low-dose CT made on the high-risk population, like heavy smokers for a lot of years, and so on, can really save lives. There is also a European statement saying that there is this viable evidence and that more or less invite the general government to address this kind of programs, but there are still some hesitating government to like in Italy as well, to start this kind of programs because of the high associated cost to the public health services, but also to some major issues that have to be addressed to guarantee a successful implementation, such as follow-up invasive tests with potential associated problems, harms to the patient, that have to be assured in an efficient way to maximize the accuracy of these programs. What it is also true is that low-dose CT programs, screening programs, generate a great amount of false positive nodules, with also some negative, let's say, aspect of the patient on the psychological point of view. So in general, it is clear that it would be needed to improve the diagnostic performance, providing a more accurate visualization of the lesions, of the boundaries, of their morphology and density. So increasing the possible spatial and contrast resolution would be really great achievement. And provide clearly as much as possible a low invasivity test. So if we speak about low-dose CT screening, I just look around a little bit about the protocols. This is the protocol showed by, do you see my, yes, by University of Milan, Milano. It is recommended, so when a nodule is detected in a low-dose CT scan, further examination is recommended if the now a nodule is found with a diameter of less than 5 millimeter. A CT scan is provided after 3 months if the nodule ranges between 5 and 8 millimeters. Okay, what we can say that if we can intervene to visualize better and characterize better nodules at these small lesions, evaluating their characteristics, but also the let's say the features of solid, subsolid, part solid nodules with their also borders and a better visualization of the border would be really a great improvement. Taking an example of typical lung nodules, adenocarcinoma is one of the most frequent nodules that you find in the lung studies, and it was found by several authors that compared to moderately and highly differentiated nodules, poorly differentiated adenocarcinoma nodules has worse prognosis in terms of high probability to generate metastasis, higher postoperative recurrence rate, and so on. For this kind of studies, high resolution CT is the typical used approach for an early characterization. There are some other authors suggesting the use of dual source computed tomography and the use of iodine to increase the contrast and the visualization of the nodule. It is effective in a lot of cases, but okay, sometimes it is considered not enough efficient, and there are still some kind of nodules, such as lipidic rose adenocarcinoma, that has not a great that has not an uptake of iodine itself. So in the end, it is not as effective as clearly radiologists would like. So the question is if could a more sensitive and less invasive approach be implemented for characterizing this nodule. Going to the second, let's say, motivation, idiopathic pulmonary fibrosis is a very bad disease, producing a progressive diffuse lung, scarred lung, with a dilatation of the bronchi and alveolar remodeling and parenchymal fibrosis. The problem of this kind of disease, it is really very severe and very, very bad, is that particularly at the early stage, it is characterized by similar histological and radiological pattern of usual interstitial pneumonia, with absence of other cases such as allergy, drug toxicity, environmental exposure, and so on. And so also in this case, high resolution CT is the key diagnostic test. But at the end, the final diagnosis is performed using a combination of different, let's say, point of view, different findings. So the point of view of the radiological, the radiologist together to the pathological, anatomopathologist and other doctors. So also in this case, an improved diagnostic method could be fundamental to anticipate as massive and characterize better this kind of problem. Looking at the clinical practice guideline for the diagnosis of idiopathic pulmonary fibrosis, it is clearly that is recommended by an international level, that you see that so after a patient evaluation, at the end, that high resolution CT is the key exam that is considered to decide if the patient has really this kind of disease. And when the interpretation of these images are doubtful, also international guidelines recommend a multidisciplinary discussion about doctors to decide what to do, but in general, no objective parameters are used to discriminate among these doubtful cases. So what we are doing with ELETRA, the aim of our preliminary study, that is clearly preliminary because we are still limited by the energy, by the flux of our beamline, is to evaluate the effectiveness of propagation-based imaging in the study of lung. So for this purpose, we used some peculiar phantom called RT-chest that we, at the beginning, had provided by the colleagues of Heidelberg University, that is capable to keep inflated by generating negative pressure some porcine lungs. This is the scheme of this. This is the photo of this previous phantom, and we place it and we study. We made several scans at different propagation distances, and we compare the images with the clinical CT at Catinara Hospital. So after a while, we managed to realize our own phantom that is a little bit more transportable than the previous one. This is called Anthony. It is a sort of monster, as you can see, with a pump for reducing the negative pressure on the head. And we developed a special large and heavy sample stage to manage it, to be able to perform CT. Okay, this is a volume rendering of Anthony obtained with scan, and you see some section of Anthony with the pig lung inside at the clinical CT at the 2 contrast window, and at ELETRA you see that it looks like a real patient in a certain sense. So this is what we hope to do. Okay, these were the first images that we obtained at the end of 2018 at the beamline with original phantom. Okay, you see here the conventional image taken at ELETRA, and as a comparison, a similar section of the lung acquired at ELETRA. What we can say in general, we are very lucky because we can provide a piece size of 100 micron with, I forgot to tell you, with single photon counting detector. Hydra from X-Counter from yes, Swedish company. So with the 10.5 meter propagation distance due to the zoom factor of the synchrotron beam, we can imagine the lung with 67 micron pixel size, let's say voxel size if you consider the same, the 3 dimension. While clearly for the high resolution CT, we have in the hospital, we have 0.5 by 0.5 by 0.9, and for the ultra high resolution CT with the single photon counting, we reach 0.2, but there are never this kind of resolution reachable. And I can say that this resolution is important to visualize some features like the interlobular septa you have in the lung that are typically 100 microns thick. Here you see indeed that all the septa are really well visible at the synchrotron compared to the clinical CT that don't always you can manage to have this kind of visualization. So since the beginning, we evaluated the possibility of distinguishing between different lesion density. This is the case when we created some artificial nodules by injecting some agarose with iodine at a different concentration. And you see that the reconstruction, so without phase retrieval, okay, providing a nice spatial resolution, but the contrast, the related contrast is not enough to distinguish between the 2 lesions, while with the phase retrieval and also considering 1/3 of the dose, you manage to visualize the 2 densities, so to distinguish in some way the density of the lesions. Also here you see that in the comparison with the images obtained at the conventional CT, a lesion that we produce with agarose is quite better distinguishable at ELETRA with compared to the other one even at the lower entrance dose, entrance air kerma. We showed that there is an increase of, let's say, there is a convenient use of the phase retrieval, and this demonstrates this scans obtained at different number of projection shows that clearly you can reduce a lot the projections, keeping the visibility of most of the details. Consider that we can go from 8,000 projection full image up to 2025 at low energy, at the minimum number of projection. And this is the reconstruction without phase retrieval. So there is, again, this already we knew, the huge gain due to the use of phase retrieval. And also there is the gain of increasing as much as possible the propagation distance as it is seen here. Here we have a distance of 0.5 that is clearly the image of the 10.7 has a better visibility of all the details, while the clinical is rather blurry for the same kind of visualization. Okay, but now which energy we need? Clearly at Aleta we were forced to work at 40, 42, we reached one case 45 keV, and we were very happy once. And because clearly it is not enough to study the lung, generally the patient has either the ribs and the spine, unfortunately for them. And so in one case we equipped our regional phantom with huge big spine and ribs. This was the work made by Christian and Willy from Heidelberg to equip this monster of the spine and ribs. And so we managed to see how the visualization of the phantom with this increased details is performed. Here you have the 40 kV phantom without the ribs, and here you add the ribs and the spine, and this is a great party we made at time because we reached 45 kV, maybe the only time, and we see that there is really good visualization of the phantom with the spine and ribs inside. Okay, but so this is what, this doesn't appear here, yes, how a full lung can appear with the 76 micron resolution. That is our effective pixel size at 10 meter. We had also, in one case, the possibility to study, oops, doesn't work, a lung, yes, just recovered from pneumonia, because in most of the other cases we had lungs from healthy pigs. In one case we found some lungs with a part that was probably affected by, you see, higher let's say, the denser tissue, probably due to the post-effect of pneumonia. And so finally, in this week, we came here and we were able to make the first study of the phantom with 70 and even 100 kV. This is how the first image provided by Lorenzo appeared. This is a zoom of this lesion. You see that there is a quite visibility, a nice visibility of the human tissue and also some interlobular septa. The image of 100 kV is rather noisy, so there could be a nice work to be done with the team and Ascar, let's say, work. But you see the dose is really low, considering that this really represents, let's say, human patient. Okay. So coming back to Trieste, so we were wondering, since we were working with the LFT, we didn't manage to find the lesion. So what we can do and how, which can be the benefit of our technique. So with the in this picture, we put together some images coming from clinical routine of patients presenting some solid nodules, subsolid nodules, and patient this pneumonitis, an acute interstitial pneumonitis. In some way, we try to mimic some artificial lesions, simulating similar kind of patterns. In this case, in the lung phantom, we simulated the solid nodule with the injection of agarose, and we see how this image is visible, or this detail is visible at the conventional system compared to the Teletra. You see how much there is the improvement of spatial resolution, allows a clear definition of the borders and also these small details. Here there was a subsolid nodule, a little bit more liquid, let's say, detail that we introduced, and you see much better here the feature and the border visibility with the synchron radiation, also this part. And in this case, we had here the example of the real pig lung with some fibrosis that simulate in some cases the situation in a less severe way, but okay, the situation of the patient. And you see how better the fibrosis is visualized by means of our technique. This is, by the way, a slice of this sample where we identify this higher density region. Trying to make a comparison with the histology, we clearly extracted the lung, it was fixed, and then some pieces were cut, the pathological part of the tissue is denser than the other part. And with huge patients, they managed to embed them in paraffin and then study with the histological study. So you clearly see that, so after all this management of the tissue, the quality of the histology is rather poor. You can try to identify a comparison with the CT, but it is not really simple. But you see a difference between the pathological, what we consider pathological and normal tissue. So in order to think about how to treat these samples after the exposure at Teletra and how to make the histological comparison, Christian found this very old protocol, fixation protocol based on vapor, that foresee the possibility to fix the lung while it is kept inflated by using formalin vapor. And this was performed, this protocol was, this paper was written in 1961, and consider how many years ago. Okay, so we copied this protocol, we used this protocol in our case with our phantom while it was inflated by the pump. And we managed to fix with huge patients, 4 to 6 hours, the lungs entirely in this way. And so this allowed us to form a better comparison with histology, and with huge, let's say, with great surprise, at least for me, we managed to see a very nice correspondence between the imaging of the fixed lung with respect to the fresh one. This is the slicing of the operation of the lung after fixation, after it was removed from the phantom. And with again a huge patient, the histological station were recorded, but you can see clearly that now the comparison is much easier and the quality of the histology is much better. So this is something that is really interesting to do for having a nice comparison between the CT and the histology. Okay, which can be the experimental protocol that we are going to implement. So the aim is to evaluate the potential of low-dose propagation-based CT in the early detection of lung cancer and idiopathic lung fibrosis. The type of exam, it will be a second level examination that should come after a high resolution CT or a low dose CT. The recruitment criteria should be not characterized nodules detected by one of the low dose or the high dose computed tomography. The suspect of idiopathic fibrosis, or also they need to better characterize a possible other kind of fibrosis, why not? Enrollment center should be the TST public hospitals, as it was for mammography, but we are evaluating also the possibility to enroll, to make a transnational access to the facility through Eurobioimaging. That is a European European ERIC collecting different kind of imaging nodes in Europe. The dose goal is to clearly to keep the dose as low as possible, if possible as low as low dose CT screening, and for the post low dose exam, and 50 at least. We didn't discuss a lot, but this is what we hope. 50% of reduction of doses with respect to the high resolution CT. Okay, the last part of my talk will relate about the new imaging beamline that is under construction at Eletra. Clearly, this kind of studies cannot be done with existing beamline for the low for the energy spectrum that we have now available. The aim of the new beamline that is under construction in the framework of the Eletra 2.0 upgrade program, that is a huge upgrade that will bring to a complete substitution of the machine with a new one and new component, is to provide a new state-of-art hard X-ray imaging beamline capable to do multi-scale imaging with different detectors, different resolution, keeping the possibility to have also longer propagation distances, fast for means for studying possible dynamic phenomena. So using the beam either in monochromatic and in the white peak modality, wide because we want to study big samples and have the possibility to perform imaging on patients, providing energy, X-ray energies higher than 50 kV, with clearly related high safety standards, dosimetry, and so on. The new source of the new beamline will be a 6 Tesla superconducting bending magnet capable to reach a very nice flux at an energy up to here you see 120 kiloelectron-volt, with a huge increase with respect to the present configuration. The beamline will be rather complicated. It will be equipped by, apart of the slits and the safety components, by 3 monochromators that will allow to cover the entire range from 10 kV to more or less 130 kV, based on a double drag system, lower, of course, for the high energy, and the multi-layer for the intermediate energy. The mirror will be provided downstream the monochromator to be able to use, to work with the white beam, but also to reject the high harmonic component. The CIRMAP beamline will be developed for most, so inside the experimental hall of Eletra, but you see here, this is the plan, this is the optic hatch, and this part will contain the experimental hatch, including the patient. The second part of the experimental hatch will include the patient station, and there will be a long rail to allow to obtain a longer propagation distance. We will able to work between 3 and 20, about 22 meters for the clinical imaging, and maximum distance of around 30 meters for the other kind of samples. The idea is to realize clinical, let's say, facility with an area dedicated to the patient, and clearly the patient will have an entrance that is close to the radiology room, and will be able to enter to the experimental hatch through this patient area here. So the path of the patient inside the Elettra experimental hall will be limited to some, let's say, tens of meters. But okay, some final consideration about the pros and cons of this kind of protocols, because we are aware that the implementation is rather critical. So if on one side the protocol will surely provide the images, better images with improved spatial resolution and constant resolution, we will have by sure an important decrease of the delivered dose. And the perspective is to better characterize the lesion, to detect them before, and to have maybe a less painful follow-up in case of some further doubts. But there are several technical problems and issues to be considered. First of all, clearly, we didn't speak about the beam height that we will have. Clearly, at 70 kV or 100 kV, you cannot expand the beam by means of crystals. We plan to expand a little bit the beam by bending the lower monochromator, but the height of the beam will be of the order of 2.5 to 2.5 centimeter. So possible motion artifacts are more critical in general than in conventional CT. The patient positioning can be a little bit tricky in order, particularly for finding the same region that has been studied at the conventional CT. There are some big patient safety issues to consider, because clearly the beam is very intense. We have to be sure to guarantee the safety standard and those limits that we want to, that are our objective of the trial. And maybe on the radiological point of view, there will be a difficult comprehension of the images that are completely new. Some very small details will be visible, and so it can be tricky. So discussion about what we are able to see. The last problem can be that maybe since the new approach will be able to see really, really tiny details, it can happen that this technique can bring some new false positive with possible related negative consequence of diagnosis and so on, and the need for further eventually follow-up test. So I think I can stay here, I can stop here saying, okay, these are the conclusions. The aim is, okay, that practically our feasibility study gave some successful results, and the doses are in general much lower than the conventional studies. And clearly the use of X-ray energy higher than 40 kV is fundamental, and we really look for and wait the new beamline that is under construction to implement this technique. The start implementation of the new beamline will be next year, after the beginning of the shutdown of the machine that is foreseen for the 1st of July. And the beam is supposed to come back in October 2026 for the first test. And our beamline will be already installed and ready for start decommissioning. In the acknowledgement, I have to remember all the colleagues of the Elettra Synchrotron Trieste, as well as the doctor, the radiologist, and the pneumologist component, Elisa Baratella, Maria Cova, Marco Faleonieri, Fabrizio Zanconati. Lorenzo D'Amico, from Monash University, and all the colleagues from the German institution, Göttingen University Hospital mainly, and Heidelberg University Hospital. Thank a lot for your patience. I am available for any question. You hear something? You hear? Now you didn't hear anything.
Well, thank you very much for that, Juliana. Really good to hear the updates going on in Electra. And I know that how all the outputs from Electra have been continually informing what we're doing here. So we're very, very grateful for that. Any queries or questions? Yeah.
Thank you. Juliana, what's the realistic time scale to be ready to do clinical imaging with the right energy? So not just the beamline, but also the Electra upgrade. And second, what will be the beam size? You said it'd be very wide, but how high?
Allora, the beamline, the time schedule from the machine is very well defined. So at least machine people judge on their best relatives that from October 2026 we should have the first beam in the machine. No, from beginning of November there should be already some first friendly user at Electra. Means the machine should start 2 months before. So suppose clearly 1 month, 2 months can be a delay, but they are making some strict time schedule. So they say that officially the Electra will be open, the new Electra will be open to user, conventional user, let's say from 1st January 2027. We will mount our beamline, so it is already under construction indeed. We will wait to mount the beamline during the shutdown because clearly you have to install the arch, to prepare the ground for the patient support, to install the arch, and so we will start after the let's say the 1st of July of next year. So this is for the machine side. Clearly, from our side, we need to start the commissioning, and it will be not a question of just 1 month, as you can imagine. The other aspect is that at the beginning, we will operate with the conventional bending magnet. We will have the installation of the super band only in spring 2026. So we start, the machine people want to make the commissioning of the machine with the conventional bending magnet and not with the super band. So, but they speak about, let's say 3 months. So these are the time scale. Now, if they will be maintained, I hope yes. If they speak with them, they say, of course, everything is ready. But you know how things are going.
And the beam height?
The beam, we have an opening, remember 5 volt of 7 milliradian. This means that we will have wide beam at 40 meters. With the patient at 40 meters, we will have something like a 30 centimeter, and the weight, the height should be around 2 centimeter. This is at 70 kV. Clearly, you can't expand the beam.
Okay. Thanks.
At least if you invent a way to expand the beam at 70 kV, I make you a gift. 2 gifts.
Yeah. Thank you, Juliana. It's exciting to see. I'm just wondering, in terms of the flux rate, maybe compared to the IMBL, what sort of scan times do you expect to be able to get?
the idea is to keep the scan within a threshold. We were said by the pneumologist that 10 seconds is a period, is a good time limit. So one scan also now is made at 10 seconds, clearly at 40 kV, but it will be this.
Excellent.
Any other questions? Can I just ask a little bit more about Anthony, because he seems to be a very valuable member of your team. I presume these lungs need replacing quite regularly. The material, yeah.
In the Phantom. We managed to keep the lung for up to 12 hours, isn't it, more or less, in the best cases. Sometimes it is a tricky operation because the lung has to be appropriately prepared. It has to be, let's say, kept with the trachea, the heart, and clearly the lung has not to be clearly have some holes, otherwise Christian is teaching it. But if the lung is in good condition, we manage to have to keep it up to 10 hours, more or less.
It changes from lung to lung.
Clearly.
We have 10, 12 hours lung. And now with the stable fixation approaches, we can also fix the lung beforehand. That's also now starting to collect lung of patients for that transplantation. And then look at the fixed lung.
So it is huge. Having found this fixation modality is really huge advantage, because now we can fix the lung in an appropriate way without liquid inside, because they have been fixed with vapor, and this is really nice.
Now, I know that a lot of the justification for what you're doing and Kay's doing is around lung cancer screening. We talk a lot about nodules, trying to see nodules and see them earlier and so on. But one of the big deals also in Australia, and this is very timely with the lung cancer screening, because we're implementing lung cancer screening in Australia in July next year. So it's really, it's really, really timely. But I think the other element for Australia particularly is around silicosis and pneumoconiosis and those sorts of diseases. And I'm just wondering, you certainly showed some very nice pneumonia images and fibrosis images, but I'm wondering about silicosis and pneumoconiosis. Is there any model to allow us to see how well phase contrast could work for those?
I think that also for those kinds of problems, the technique can be rather effective, because clearly you have a better resolution, a better contrast than the conventional technique. And so I think in those cases it can be even easier to say something on the diagnosis, I think.
Okay, thank you very much.
Thank you.
Good. Okay, well, I realize I'm standing in the way between you and your lunch, and it's a dangerous place to be, so I really will not be here for very long. But firstly, I should say, are there any questions for anyone from this morning that people would like to present? Or any comments about how we should move forward? Yeah, good, Daniel.
Yes, I think it's clear that when the grant will run out, we're still going to be in the middle of doing a lot of highly relevant work, and we'll need to take it further. So at which point do you think we'll put our heads together and say, what next? Where do we apply? Do we apply for which direction, which funding body?
I don't know if anyone has any comments on that. I think it's something that we have to, as we mentioned before, Daniel, I think it's something we have to start thinking about straight away. I think we've got money till 2026, but as I was talking to Chris earlier, we have now got a vast amount of knowledge we didn't have 3.5 years ago. And it's important now to utilize that and make the most of it. I think we'll have to, and what I intend to do in the early part of 2025 is set up a working group just to look at where the next round of funds can come from. But I do think we may have to look at this in a multifaceted way. For example, I'm sure the lung people saw that last week they announced the MRFF chronic lung disease money, which there's something like 22 million available through that scheme. So we may have to sort of look at, what funding there is for lung, what there is for breast, and so on. But I do think, and you can see it from the work we've seen presented this morning, we are in a very powerful position. We've got lots of data, we've got lots of outputs. This weekend, I saw 3 papers that are about to go out from projects 1 and 2. We're in a really, really good position to move this forward. So I would think that by getting a number of us together in early 2025 to focus on that, I think we should hopefully have a path forward.
Yeah, and one thing I'd like to add, we have to be aware of, as you know, ANSTO put in about 5 million into the infrastructure for the clinical application. But now the writing is clearly on the wall after 26, which is when we come to the end of the 10-year guaranteed funding that came with merging into ANSTO. There will be no more project money. We'll be competing with the whole organization. And we've basically been told that it will be extremely bleak. There's no way. Pretty much all our projects are being canned now. And we've basically been told, if you want to have any decent money to invest on anything, we will have to go outside and raise the funds from someone else. Nothing will come in through the ANSTO funding anymore.
Yeah. And I think we're in a position to stand on our own feet. I think we've got a lot of infrastructures and data and so on to allow us to move forward. And I think if you are looking at some case size earlier, we've got these infrastructures, for example, with the radiologists in breast imaging. We're obviously very thankful to have people like Mara and Darren Lockie and Mary Rickard and people like that involved. But in lung cancer, we can see that Kate's working with Nigel Summerfield and Catherine Jones. And Catherine Jones is one of the leading cardiopulmonary radiologists in the country. And to have those infrastructures puts us in a very good place. But I think we've also got to go beyond that as well and work with some of these institutions, such as Lung Cancer Foundation and Cancer Australia, because there's currently something like, I think, 300 or 400 million going towards the lung cancer screening project, for example. So we need to be working with these people to make sure that we have funds for the future. Yeah. Any other questions or comments? Thank you.
Sorry, my question was more about scaling up. So if this is successful, are we just going to build IMBL2 next door to IMBL and IMBL3? Like, what's the goal for really scaling this up when it works? That's sort of a question for you, Daniel, and Juliana, and people in that kind of space.
Do you want to pass Daniel? I don't know if you've got any comments on that.
If it works and building and copy and pasting IMBL2, IMBL3 next door, we can actually. I don't think it'll happen.
But I think the point you're making is a good one, and looking at one synchrotron to provide the solutions, we may have to go beyond that. And Juliana was talking earlier today about synchrotrons working more closely together and having more of these sorts of events, so we can move forward in a more collaborative way. And I think that's important we look at those sorts of things.
Synchrotrons, or what's the plan?
So I'm a representative of the new synchrotron imaging group. So come talk to me about it. But we're looking 15 years in the future, maybe. So there is a plan for a new synchrotron. What?
If ever.
If ever, yes. The difficulty of getting this one built in the first place, was the trick of getting another one, but there is a plan.
Yeah. Okay.
If it's an ANSCO project, it won't happen.
Thank you. For those of you who don't know me, I'm Keith Nugent. I'm part of this team, but through my other responsibilities have not been coming to a lot of these meetings. It's a great pleasure to be here in person for the first time, I think. And I think for my role as just coming off from being DVC research at ANU and listening to what was being presented here today was been fascinating. I would like, and perhaps we could think about this, Patrick, is how we can do this, is think about what, now I'm sounding like a former DVCR, but what is the elevator pitch, right? So what will we say, what do we expect to be able to say in 2 years' time at the end of this project? What did we deliver? What will that actually look like? And I've been sitting here today trying to work out what that might actually be. And I don't quite know what it is yet. Maybe in the summary you can perhaps, you may have a clearer idea, but I think having an idea of what that delivery will be, and then very quickly, if we can identify what that will look like and use that to build for the next phase. So having a lot of information, a lot of work, a lot of great results, which we clearly have got, but how do we condense that down into a coherent picture? Because the sort of money that we're going to need is going to require that sort of, yes, this project has really delivered, and this is what it has delivered, and what can we do next? And I think that's something we do need to think collectively about what that looks like.
Okay.
So I'll just encourage us to have that conversation quite quickly.
Good, thank you. Yep. Yep.
You think we should start to think about should we start thinking about, I know I don't really like the expression, but like a horizon scanning workshop, I mean, this workshop is wonderful and look at instantaneous picture of where we got to and the results we get. But we would need, I think, a really serious, detailed discussion of all the key players to get to that, to try to imagine where will we be in 26, what will we have clearly shown and proven. I mean, I'm reasonably worried about what's going to happen when we put, a human volunteer on the bed, what will happen to image quality, and something we discussed with Renata when I was in Electra a few years ago. We don't know. We don't know what will happen when there is blood flow. We don't know what sudden challenges will have to be overcome with AI or with de-blurring, a new kind of blurring or whatever. We could have some serious work to be done once we have real data. But we would need like a clear conclusion. This is what we proved. This is how we can export it. And to get to that, sellable package, I think we will need to get together to work on it in a very kind of detailed technical way, not just an encouraging overview of where we got to.
Yeah, look, I think, Daniel, I think that's right. But so if at the end of this, and again, I'm riffing here, so please return a bit underappreciated where the progress has been. But if we can say that either lungs or breast cancer, that the use of, we have shown definitively that the the use of phase contrast X-ray radiography gives us better contrast for some of the things that we need to look at. And we can say that, we can put our hands on and say that is something that we have demonstrated to be the case. And this is what we need to do to turn that into something which is clinically significant. So there you got a real something you can hang your hat on and say that is something we have shown to be the case. And it is around contrast and signal noise ratio, all the other things that we've been talking about. But that is why this is working. This is why it works better. And then build on from that. So I think that's, but going back to your previous point, then I think having that sort of discussion would take a fairly informal workshop where we do look at what we've really got, and see if we can form something to look at where to next. But I think it would need a workshop. I mean, it'll definitely need that kind of thinking to really articulate where's that money going to come from? Because everybody in this room knows it's going to be a lot of money to do that next to get to that stage where it will be clinically significant. So it's going to have to be a really strong message, but we did get that. We did make that message when we got the IMBL funded in the first place, and we've done it now. We're getting this very large synergy grant, so the message is there, and there's a track record. So let's just make sure we know what that track record looks like, and this is what we've done, and we will be in a world-leading position to make this happen. Yeah, that's your kind of pitch, I suppose. But with that, it's there surely, but we do need to pull it together. Or we will need to.
Yeah, thank you. Certainly the aims of the Synergy grant was very clear, particularly around the breast cancer, that we were going to end up with a form of imaging that was better than what we currently have. And I think the evidence that we're increasingly seeing, particularly from part one of the work, is that we are achieving that, that we have now got a system of imaging that is improving sensitivity, particularly for the more junior radiologists. It's improving specificity for more senior radiologists, and overall the ROC is higher with this new form of imaging. And I think obviously the clinical trial is going to move that further forward, I would hope. There's a lot hanging on this clinical trial, to make sure that the patients can tolerate it, that the results we have seen so far with the mastectomies is borne out with women. But I do think, I'm hoping, Keith, that at the end of this, we will have that goal achieved, that we now have for the first time shown that we have a better way of imaging the breast, and it may be around particular densities or whatever, but we have a better way of imaging the breast. And I think Kay's work and Juliana's work around the lung moves the whole, it may be at a little earlier stage, but it moves all that forward significantly as well. But I then think it's complemented beautifully with Marcus's work, because the question will be, how far away is this clinically? We can't X-ray all these people in a synchrotron unit, and we've also shown advancements there as well. So I think we have an extremely good story to tell when we go to our next round. Yeah.
Yeah, I was just going to say, sort of in line with that compact light sources, I think that what's amazing what we're doing at synchrotrons, but of course the translation to the clinic is essential. And certainly the source that I have is not going to cut the mustard for volumetric imaging of patients. And one thing that we were hoping to get was like the Munich light source, the compact light source, 3-electron laser, inverse Compton source. We were hoping to get one here at Monash before the company went under. And there aren't too many other companies no other companies that are selling them just yet. But there are a lot of people around the world who are designing these sort of new technologies. For example, Susie Shi at University of Melbourne. So I think that maybe for the next step, whether there's another Synergy grant, if that's possible, or an ARC Centre of Excellence, to incorporate accelerator physicists as well, potentially into helping design the new technology, and maybe even detector companies as well to get better photon counting detectors, energy resolution into that mix as well.
Thank you. And I should say the other output as well from all of what we're doing, and this was important for Synergy, is the cultivating a whole new group of researchers, and we've done that extremely well, I think, in terms of outputs, in terms of postdocs and PhD students and so on. And a lot of the work that we have seen here today has been produced by those younger researchers, which is tremendous.
So I'd just like to reflect on what Marcus has just said. I think that's really significant. I do know when I left ANU about 6 months ago, there was a lot of interest there in which company was Monash working with? Which one? Right. Yeah, there's another company whose name has escaped me now that ANU is very interested in working with, also in Silicon Valley. So that there is a potential there to build a team around those small compact sources. A lot of interest in that. We're probably not going to get a free electron laser in Australia, I think, in the foreseeable future, but we might get one of these compact sources. They're still very expensive and a lot of facilities around them, but there's a lot of interest in what they can do. So that might be but you're right. I mean, we have to have if the compact source is going to work, it has to be something like that. So the question is that going to be, is that a way to the future? So I think it's something we have to have on the table as well.
All right. Any last minute comments? Yes. Yeah.
I just wanted to add that we should also start probably explore collaborating with vendors like Hologic and Siemens, etc. So I know that Hologic has collaborated in making a phase-sensitive DBT. So if we are getting closer in 2026 with proving how technology outperforms, for example, with digital mammography, I think they should be interested in investing and working with us.
Good. Yeah. Thank you, Nick. That's great. But also about even commercializing our own ideas, like seeing the sort of work that's coming out of Monash around the compact light sources and other algorithms that we're developing and so on. And maybe we need to be thinking a little bit more commercially around this.
Thanks. My name's Cindy. Just a random thought about potential funding sources looking forward is the Australian Futures Fund. If that ever gets through Parliament, that could be a really important source for something like this because it is focused on innovation and the kind of things that we're talking about here, particularly if we can get the compact thing happening, and if it could then end up being even, pardon me, an Australian production, then that would be potentially another source to look at.
Thank you. All right. I think we've achieved, I think, a lot this morning. So thank you all very much. Thank you to our speakers. Thank you for all those people who have traveled so far. Yeah, please have a great lunch and we'll keep the discussion going. Thank you.